Okay.
I'll do the introduction. Yeah.
Good morning, everyone. We're here again for another great grand round. For those of you that are participating via live streaming, if you are not connecting, check your email. I just sent out a with high importance email. For some reason, the tiny.cc link is not working, so I sent out a new link about 8 or 10 minutes ago. So you should be able to log in then. For those of you here in the room, the entire ceiling is mic'd. It will pick up any sidebar conversations, so I don't have to chase with a microphone like we did last month to catch people's comments and to ask questions. It will already, everybody online and in the room will be able to hear it. So beware of your sidebar conversations. Putting that out. I'm very pleased that today we have two relatively new medics, a Fire 2 and a Fire 3, that have stepped forward to come and present. So you all that have been veterans for a long time, I'm just stepping forward. There will be grand rounds next year. We don't have the dates yet, but I do have a flyer for those of you in the room. If you have a call you might like to present or talk about, fill out the form and you'll send it to Ray in the back. You all know Ray. Because I'm retiring. So I won't be anyway, another sidebar. So we're going to go ahead and get started, and our first presenter is Zach Portar, and we have a PowerPoint, and we'll have questions, etc. as we go through. Welcome, Zach.
All right, thank you. Good morning, everyone.
Good morning.
So my name is Zach Portar. I'm a Fire 3 paramedic, recently certified in August of this past year. Went through Montgomery County's program. So this call happened for myself as my third day as a medic. So it was kind of eye-opening. It was something that I really wasn't expecting. And so I'm going to kind of explain it to you guys a little bit from the dispatch all the way through. And if anybody has any questions, kind of like what I was thinking along the way, and then at the end I'll summarize the lessons I learned from it, which might answer some of your questions or hopefully give you some insight on what I saw. I apologize up front to DeBrule. He was on the call with me as well. I didn't realize we were both going to be here today, or he would have been involved in the presentation a little bit more. But he's up here so he can answer any questions and contribute as well. So the call itself, we're dispatched to 3227 Belpre Road for an unconscious ALS-2 on the new interfacility dispatch. And the units dispatched are ALS 742 with paramedic DeBrule, myself on paramedic engine 718, and ambulance 742 Delta. I'm sure everybody's very familiar with 3227 Belpre Road. It's a two-story skilled nursing facility. The room 100s are on the first floor, room 200s are on the second floor with elevator access in the middle of the building. The call that we're going to is on the first floor. As we go in, it's going to be to the left of the nursing station. We're dispatched for a male patient with, like I said, unconscious. We arrive on scene, and we have a 64-year-old male. He's sitting up in the hospital bed, and he's working to breathe. He's posturing. He's holding his chest. He's very very uncomfortable. He's very talking in 2 to 3 word sentences at most. And right next to him, they have the vitals cart for the facility, and his initial O2 sat. He's on 15 liters non-rate breather, and it's 85%. So that's kind of the picture that's painted up there. So right off the bat, looking at the patient, I think we both agreed that this patient was pretty sick. So our physical exam that we started, we go ahead and we check his work of breathing. Paramedic DeBrule checked his lung sounds. They were clear bilaterally. They were shallow and hard to hear because they were so rapid. He was breathing so fast. Like I mentioned, the vitals cart was 84%. They didn't have any other numbers on there. So we go ahead and we turn the life pack on. We put him on our pulse ox. we get 83% for ourselves. Our initial blood pressure, 176 over 121, and I put there the heart rates of 41 as it was trying to read, and then 135. So we know kind of right off the bat that, he's a tachycardic to start. First thing we decided to do is let's try to fix this breathing problem that we got going. So we decided together that we were going to put him on CPAP right away. So we're putting him on CPAP. As we're setting that up, we're also getting the rest of the monitor together, and the patient at this time had to use the restroom. So during this whole episode, he mentioned that he really needed to go to the bathroom, and he wasn't really cooperative with us. So we're kind of delayed in treatment a little bit here because now he's sitting on a bedpan as well as all this going on. Finally, as you can see, a few minutes later, we get him hooked up to the monitor. He's done going to the bathroom, and we do our 12 lead. So he's still on CPAP, and this is the first 12 lead that we get that you have in front of you here. And it's up here on the screen for the online viewers here if you can see it. So as you can see, we kind of looked at it. We felt on scene that it was borderline being a narrow complex. So we decided that with that in mind, it kind of led into our next treatment. Just to kind of fill in the rest of the history here from the facility, he's got no known drug allergies. Sorry, his medication list was provided to us, not recorded in the report for me to pull up what exactly he was on, but we transferred it to the hospital. He ate breakfast around 8 o'clock. The staff said he ate normal as they do their rounds. I think they have a little cafeteria, so he was ambulatory. He went down there, walked himself, and the events that led up to it is when he was returning from the breakfast, he was walking down the hallway. He had a sudden onset of shortness of breath. He collapses in the hall. The staff helps him back up to his feet, and they walk him back into his bed, where his respiratory distress starts to become greater and greater until we found him in the posture, in the hunched over position, breathing. His medical history is he's got diabetes, seizure disorder, hypertension, being treated for sepsis and a bacterial infection resulting in the right toe amputation, and there's a surgical drain and dressings in place. He has no history of any cardiac at all, and that's kind of where we go back to that 12 lead and stuff. So we're looking at it and we're like, okay, so we don't think that he has any previous cardiac history, but this is the 12 lead that we have in front of us. So after about 2 minutes on CPAP, the patient, he's very restless. He reaches up, he pulls the mask off his face. He says, I can't tolerate this. It's not working, and I don't want it on. It feels like it's constricting me. So at this point, especially being a new medic, I'm like, oh no, like this is not working like I thought it was going to. So we decided together that we were going to load him up and let's just start going to the hospital. So that's the best way to get him moving. Let's get on the road, and hopefully we can get something from there. So we package him up, we move to the EMS unit, and as we put him in there is when he starts complaining a little bit more. He's saying we got him in an upright position. We got him back on 15 liters per minute non-rebreather, and he starts with the impending doom comments. So he's like, I really think that something's bad gonna happen to me. This isn't like, I can't breathe. I'm having a hard time catching my breath. So we started kind of talking back and forth a little bit, and we're like, should we consider a cardioversion? Should we not? We decided at that time that a cardioversion would not be appropriate. His blood pressure was still good, still stable in that sense. And then we're trying to figure out, is this a respiratory issue or a cardiac issue? So like I mentioned before, he doesn't have any history of cardiac, but we got a 12 lead that's tachycardic, and we have a patient in respiratory distress that we couldn't fix with CPAP. And like I mentioned before, the lung sounds are clear, there's no wheezing, and so we're not thinking down the line of like nebulizers or anything like that. So we get ready to transport here, and like I mentioned, we got him back on the oxygen. I gained IV access, and I mentioned that I thought the patient was pretty sick, so I went ahead and put him on the pads ahead of time with the impending doom that he mentioned that he had, and paramedic DeBrule consulted with Holy Cross. At 11:50 or so, if you guys flip to your next page, this is in the back of the unit right before we pulled off. We did this second 12 lead. We had him try to perform vagal maneuvers, so we're starting to think that this might be like a borderline SVT type of ordeal with the fast rate. So we started to try to do vagals. They didn't work. He was compliant. He did it twice, but we didn't get anything. So as we started to transport down the road, we decided that we were going to try to push adenosine to slow the rhythm down. At this point, I think that we both thought that this was a new onset of some type of cardiac issue, so that's how we decided that we were going to treat it. If you flip to 12 lead 3, sorry, there's 12 lead 2 for the online viewers. And so where you see here that it's, we lost V1, V2, and V3, he was so diaphoretic at this point that the leads were just coming off nonstop. Like, we went through probably a whole pack of stickers on him. So we were trying to keep leads on. We were trying to tape him down at this point to not lose it. So that was a big challenge. And the restlessness is increased really to the point where he's not sitting still for us anymore on the stretcher either. So it presented a challenge to the rest of the call as well to maintain this electrical capture. 12 lead 3. So this was after we pushed the 6 milligrams of adenosine. We slowed it down. And at this point, we both looked at it and we said, okay, clearly now looking in like lead 1 and lead 3, we were like, this is AFib RVR. So from that point forward, we decided we were going to stop with the adenosine treatments of a rapid tachycardia, and we were going to go ahead and we were going to try to get him on cardizem. So as we began to draw up cardizem, DeBrule was drawing that up. I was kind of trying to work with the patient to keep the leads on at this point. And I try to keep the leads on, and at this point, the patient goes unresponsive. So he's out. He's not responding to us anymore, and we decided at this point that check the pulse. He still had a pulse, and we were like, okay, now we're going to attempt to cardiovert this guy because he's unconscious, he's unstable. So we go ahead and we charge up the monitor, and you can see that in the bottom strip there where we started to charge. We added our sync, and then his rhythm kind of just went to nothing that was going to work for us. So the cardioversion did not work. It didn't go through. It didn't have a R wave to capture on, and we were not able to administer a cardioversion there. We were arriving at the hospital by this point. We're backing into Holy Cross, so we just started compressions. There was another crew there, another ambulance crew who saw us struggling in the back there, hopped in right away and started grabbing stuff and took over CPR for us to help us get inside. We went right inside into Bay 1 there at Holy Cross. They got him switched over to theirs. They intubated him right away. We didn't have time to do that in the field when it happened. And he received 1 defibrillation, I believe, correct? And from the hospital, and they got him back at that time. After a few more subsequent cycles of going into cardiac arrest, they were finally able to stabilize him through the treatments in the hospital, and they got a ROS, which they maintained after the 5th time that he coded. So it became like a repetitive cycle. We kind of hung out there for a while helping him out, and it was just back and forth for about 45 minutes. They gave 1 epi and 1 bicarb in the last round of the code that helped them. And this was also part of the follow-up email. I got some of this from the hospital too, so this is kind of like piecing it together. They decided their plan of treatment was going to be to start the echocardiogram once he was stabilized enough to do so. So they did that, and they diagnosed him with a dilated right ventricle and a flattened septum. They then took a chest x-ray, and they found a right-sided pneumothorax. They weren't able to tell if that happened previously or post our manual CPR compressions. Again, once he was stabilized in the hospital, so this is further down the road, a few weeks later, he did develop the rapid AFib again, and his rate went back up into the 150s. So that ended up becoming something that happened again in the future. And he had a chest CTA, which ended up confirming that he had a massive pulmonary embolism. So this is kind of the breakdown of the times from the hospital, which I summarized in the slide before, but this is kind of like how they gave us the dates and the time frame. So the call happened on the 6th, September 6th. On September 7th is when he began opening his eyes spontaneously. He looks around when his name was called. He wasn't able to follow any commands. They reduced him off of one of his pressor medications, and they took him off the amio drip, and he remained in a normal sinus rhythm at that time. On 9/9, they extubated him, and on 9/11, that's when he had his first seizure activity, so they put him on Keppra at that point. In 9/20, so 2 weeks later, he was discharged from Holy Cross back to the rehab center, or to a different rehab center. And on 10/25, he was stable enough to go back to the hospital and receive a partial foot amputation for the rest of the sepsis that he was initially being treated for in the Belpre Center. So what are some things that I learned as a new medic? I know it seems kind of simple. A pulmonary embolism, we talk about them all the time. I remember learning about it in class, but I didn't really know how it was going to present, per se, until I saw this happen, and I learned about it afterwards. So, and a pulmonary embolism is a clot that's in your artery between your heart and your lung. It breaks free and then gets stuck. So, like I said, what are some lessons that I learned from this whole thing? And it's that I need to connect the dots. I need to see the whole picture. I need to be able to put together the diagnosis, the respiratory and the cardiac, and not get stuck into one treatment plan or one treatment protocol. I learned that nasal intubation, this probably would have been the perfect patient to nasally intubate early in the call. It wasn't something that I felt like I had a lot of exposure to, but now that I see somebody, I know exactly what to look for to think about that skill a lot earlier in my treatment. A big thing was eyes on the monitor during the cardioversion. So when you looked at that third strip there and you saw that the rhythm changed from what we initially had and then when he went unconscious, you can see where I turned on the sync, you can see where I charged it, and the rhythm isn't the same rhythm on that lead that we had originally seen. So I learned there that I need to be very cognizant of the rhythm that's going on behind the monitor for the patient at all times during the whole call. Fast cardiac rhythms could be a sign and symptom of another disease. It's not always a cardiac problem. And like I mentioned with the pulmonary embolism, and I'm going to talk about that on the next slide too, that the tachycardia ended up being one of the huge signs that I didn't connect the dots back together on. I'm going to talk about on the next slide also some changes on EKGs that help us identify or confirm that a pulmonary embolism may be present. And the reason that I got here today is because after this call, I think that we both agreed that we were kind of like, wow, like that didn't go the way we thought it was going to. Especially as a new medic, I really thought, everybody that we treated was going to get better. I know that kind of sounds silly, but I think it's the new medic syndrome type of thing. And I really wanted to know, like, what did I miss? Like, how could I have gotten better? And hopefully by doing this presentation or giving this information forward, that I could help somebody else maybe say the next time they see someone, oh, wow, that might be a pulmonary embolism. So Captain Kaufman, he worked with me on a lot of this, and he found this website and gave it to me. And this is right from the website here. Sorry that it's a little bit small, but I have some notes on mine that we'll look at on the. We'll be using EKG 3 to look through these real quick together. So one of the big things that we look for is we have the atrial fibrillation with RVR. So we have the heart rate of 188. I'm going to go back to the slide so people online can see it there. So we have 188 beats per minute, and we know that we're in AFib. So that was one of the signs and symptoms there to help us identify the PE. The right bundle branch block, like we have it up here in the box. And then this was kind of hard for us to see, and with you guys having it in front of you, it really looked like if you count the boxes, it's really close. It's hard to tell with the fibrillation that's in there. So it's one of those things that I don't think either of us, not that we neglected to see it, but I just don't think that it registered because we were looking at the complex and didn't really put it all together. T-wave inversions in V1 through V4. So if you look up in V1, definitely a little T-wave inversion up there. S-waves in lead 1. I think the first complex probably shows us the best one. And then Q-waves in lead 3, which we have present. And again, inverted T-waves in lead 3. And it's kind of hard to tell, but I think that probably the second and third complex might have slightly inverted T-waves there. So I think that using those signs and symptoms together and these identification points that we can see that. And you can see here, some of them gives the percentages of the patients. So with the AFib, it's actually only seen in 8% of patients. So I thought that that was actually kind of unique there, that we had a patient that fell into such a low percentage of signs and symptoms. The S1, Q3, T3 pattern is probably the most pronounced or the easiest one to identify and help us remember it. And working through the 12 lead number 3 there, we identified those points in that EKG. And again, the right bundle branch block, we found that in there too. So.
A question online, Zachary. Well, how did the patient's chest pain present? Was it something unusual? Was it strictly the normal pain? I have pressure on my chest. It might have leaned toward PE, or was it just a normal chest pain presentation?
Do you remember exactly? Because I
recall it was pressure that he described. Yeah, over the center of the chest. He described having some type of pressure. Felt like something sitting on the side.
So paramedic DeBro, I don't know if you could hear that. I said that he described it as a heavy pressure, like he was sitting on the chest. The way that he described it, it seemed, I would say that it seemed like it was probably from the respiratory distress that he was having. Would you agree? Yeah, I don't necessarily think that it was like a cardiac, like a MI type of chest pain, but he was working so hard to breathe, and so much of his muscles and chest cavity were moving to move air that I think that was probably the cause of his chest pain or discomfort, and that might have just been the only thing he could relate to at the time because he didn't know what was happening, that he couldn't catch his breath. So the references for this report, got the EPCR paperwork and used that to help us clarify everything. Again, I mentioned Captain Ben Kaufman, and he helped us with getting the follow-up emails from the hospital. WebMD, just to touch on the physiology of the pulmonary embolism, and the PE EKG changes came from, the following website, which was sent to us as well by Captain Kaufman. So that's our call, and at the end of the day, I think I mentioned in like lessons learned that we kind of misconnecting the dots there, and it was interesting. It definitely took us down a road that I think we both were scratching our heads after the call, going, "What did we miss? Like, how did we miss this?" But so it's definitely a good learning experience. It was overwhelming as a new medic as well. So Does anybody here have any questions, comments? Anybody?
Did you guys do end title at all?
Yes, we did. I don't remember exactly. I want to say I think it was in the, was it low 30?
Already in the unit, I believe. If we did it here, it doesn't give us a reading about what we got.
Yeah, we hooked him up to it, but we don't have the number of what it was. So I'm sorry.
No, I was just curious, 'cause normally you would expect that to be low.
Yeah, I think that just if I didn't record it or it didn't get picked up like in the EPCR reports, and the number. I do remember us trying to get it, but
Yeah, the fact that the end title sensors for the nasal cannula is expensive, which is unfortunate because it's such a great, to be used routinely
sure.
would be nice, just because you get all kinds of great information off of them. But like I said, I think they're like $40, $50 a piece.
Yeah.
Doesn't make sense for every patient.
Yeah, absolutely. And I think most people in here are probably pretty familiar with going from Bell Creek Road there to Holy Cross. It was only about an 8-minute to 10-minute, if that, emergency transport time, and the road was pretty clearly open. It was 10 o'clock in the morning, I think 9:45, 10 o'clock in the morning. It wasn't too late. So a lot was happening very quick, and with him deteriorating and then going into like that impending doom, and then the code by the time we got there, yeah, it's a number that I don't recall what it was
Can
exactly.
you see what was the treatment in the hospital as far as how they actually cleared the embolus?
I'm sorry, what was just
I was wondering how they actually were able to, how the embolus was cleared.
so when we went into the ER and we kind of told them the story and such, I do think one of the ER doctors said this might be like a PE. Somebody did catch it early. Somebody mentioned it and said that. And then I think the big thing was they had to get him stabilized before they could send him in there to get the the X-rays and the screening done, all that. So once they got him to stop going into cardiac arrest, and they were able to diagnose that, then they did confirm that with that chest CTA.
Yes, that'll be.
I don't recall exactly. Any other online questions or anything?
This Chris Chizo chimed in that capnography and pulse oximetry usually aren't affected unless it's a saddle embolism, so a large embolism. That will be the only one that would affect capnography and pulse oximetry.
Well, I thank you all for your time this morning and following along.
Great job, Zach. Thank you.
Thank you.
If he's alive, to talk about it after. resident. So again, two brand new medics who are stepping forward. So we're very pleased to have you here and present to you.
Thank you, Lena. As she said, I'm Jose Perez. I got my medic October 7th of this year, and I ran this call with paramedic Arthur White while I was a resident. Yeah, I'm assigned to station 12B, by the way. So I call this headache ALS1 at Cherry Hill Road in Plum Orchard because that's where it actually happened. It happened August 29th, 2019. Happened around 12:21. We're actually getting lunch at that time. We arrived at the hospital at 12:53, and then we clear at 14:22. Weather conditions, it was partially sunny and around 86 degrees Fahrenheit. Dispatch information. So medic 712 and truck 715 were dispatched for a headache ALS1. So that caught my attention. And then on the incident description, it said, complainant says that his head is hurting. Says something is inside his head. Wood or something pushed down in his head a month ago. And in this occurrence, they actually nailed it, pun intended. So the problem, head hurts from a traumatic incident about a month ago. That's what it said on the dispatch. And patient information, I had a 21-year-old male. So this is the intersection where we picked him up from. This is Cherry Hill Road, and right here is Plum Orchard. We're actually getting lunch at the Popeyes on Cherry Hill Road. We're actually trying the new Popeyes chicken sandwiches. Delicious, yeah. So in the middle of eating, we got dispatched. And the patient standing right here, waiting for us to arrive. So truck 715 arrives. The officer gets off the truck, we put him in service right away. And so normal traffic conditions, clear weather, and I find a 21-year-old male standing on the sidewalk, like I said, waiting for EMS. He appears homeless, he's unkempt, he's wearing multiple layers of clothing on a hot sunny day, and he's ambulatory. So he says, I have a headache, and he points to the top of his head. So he walks to the ambulance, and we sit him on the stretcher, and then we take a look. So he has a headache, no other complaints. And he says that about a month ago, while he was sleeping on the street, 5 guys jumped him, held him down, and he stated that they hammered some nails, a no number of nails to his head. And like I said, this happened about a month ago. So he had been walking, living with nails in his brain for about a month. And the reason why he called 911 is because his headache got worse. So sit him on the stretcher, and we see this bad boy right here. So this was definitely a red flag for us. And anterior to that nail head, we see another penetrating wound, purulent. So we're thinking possibly at least 2 nails. Medical history, he had none. He's 21 years old, no allergies. I asked him if he was any drugs because the way he was acting was a little weird. He said no, he just smoked marijuana here and there. On my physical exam, well, he's alert and reading ×3. He's answering to questions coherently. He's ambulatory. He's moving all his extremities. His pupils are pearl. Breathing is fine. The only abnormal finding is the nail to the head and embedded, and it was on the right parietal bone. And the purulent puncture wound anterior to that. Also, the way he was answering and talking, he had a flat affect. His facial expression did not change the whole time. anytime I would ask him something, he would just turn around and answer, but like his facial expression would not change. So there was no obvious bleeding, and I did a full trauma exam, palpated his extremities, nothing else found. So my updated impression, I was astonished. I was like, are you serious? And I asked him, dude, why did you, I mean, next time this happens to you, or hopefully this never happens to you, but if it does, give us a call right away, and we'll take you to the hospital. Please do not wait. A month. So for interventions, we monitor vitals and ABCs. Pretty straightforward. He was tacking like borderline at 105, but everything else is normal. Good pressure, good oximetry. Yeah, I did a quick 3-lead, and I obtained IV access with an 18-gauge needle. And we kept the vein open, KBO for fluids. So I did a trauma consult with Suburban Hospital and through MRC. I called it a category Bravo, priority 2, due that he was not unstable and he had been living like that for a whole month. His GGS was of 15, and they did not give me any orders. I don't think they believed me, because they were like, proceed to the main ED. I'm like, okay. All right. So en route, I had no changes. I kept talking to him, and he kept answering questions, making sense, I kept monitoring ABCs, vitals, everything was fine. Which was a good thing, because I was freaking out. So transfer of care at ED, they did obtain a second IV access. I should have done that en route to just save them some time. When they suspect a major infection, they get blood cultures from both sides. So that's something I could have done en route from at least 2 sides. And I think they got a CBC, CMP, but I'm not sure. And they sent him to the CT machine right away. When we went to the main ED, the nurse takes a look at his head, and he's like, we need to get a doctor here right away. And the doctor arrives, and then she gets behind the patient, and she takes a look down, and she's like, what the heck? Like, she couldn't believe it either. So that's the CT scan of the head. You can see 3 nails embedded into his brain. This is the one we saw, the nail head that we saw, and this is the purulent puncture one that we cannot determine if there was a nail there or not. But yeah, there were 2 there. Yeah, 2 additional nails. Well, we got this from the EMS duty officer. Apparently, he goes to Hopkins, and they were able to retrieve the nails, and he's alive, and he has no neurodeficits. And the reason why this happened, because he was involved in a gang, and he was trying to get out, and the only way out of the gang was to get nails to the brain. I don't know what kind of gang was it, but a very bad gang. And so this is not an isolated case to penetrating brain injuries. There are multiple cases online. I found this one. This was self-inflicted though, but people do survive, and they do recover. The guy on this article, his GCS was 15 like mine, and he ended up surviving as well. So lessons learned, always do a good assessment. Yeah, pretty much. You guys have any questions?
Has he shown any blood or anything like that, or was just the nails?
It was just the nails. I didn't see it bleeding.
You don't have any follow-up with him?
No. I never touched bases with him.
Was he in pain? Did you give anything for pain or anything?
No, he said that he was like moderate pain. So, yeah. I mean, the headache obviously worsened. He was in pain, but it was tolerable.
Is the assumption that his affect was a result of the nails inside his brain?
I believe so. Not entirely sure. Yeah.
Just curious if it went back to normal.
Right.
He didn't use a hammer to get the nails out, did he?
This is true though. Like after we went back to the unit and to retrieve his belongings, we found in his pocket a pair of pliers. So I suspect that he tried to remove them himself. Yeah. Yes, sir.
A question online, what was the door-to-door time? I think it was about a month because he waited quite a while before.
Yes. Yeah, whole month. Yeah.
What was how much time do you know at all spent at the hospital or at any kind of rehab or?
That I don't know.
Okay.
I just know that he went to Hopkins and they removed the nails there.
Okay.
Yeah.
Do you know if they transferred him the same day to Hopkins, probably?
No, I can't say. All right. Okay. I don't see any more questions. So.
No, nothing else online. Thank you.
All right.
Awesome.
our next presenter is a friend of mine. She's presented here several times before. We've had a couple of stroke conferences over the years. About every 3 or 4 years we have one. And she was here at the last one a couple of years ago when we were in one of the big 222, 224 rooms. Sharon Hairston is a nurse practitioner and works at Holy Cross in their stroke program, and she brought some stroke cases to challenge you all to think about. Okay, so Sharon, welcome.
Well, thank you for having me back. Good morning to all of you and everybody on the line. This is actually my first time ever doing a kind of an online real-time lecture, so good morning. And I want to first start with thank you guys, because you guys are our front line when patients call 911. And actually one of my new favorite shows is 911. Do y'all watch 911? So I see some frowns, I see some smiles, okay. Well, for those who are 911 fans, it was a really good episode on Monday, so you should check it out. It actually is a pretty good show. But what's that?
It's on Fox.
Yes, Fox 5. So Linda asked if I can just come back and do some stroke case studies, because you guys tend to seem to love to see this different type of stroke case studies. So hopefully I have some cases that will pique your interest and also give you a couple of updates that's been going on. Stroke, it's never good to have a stroke, right? But what I would say is the exciting time for stroke care now, especially in the ischemic stroke rim, because we are expanding our windows for TPA with recurrent research trials. We're expanding our windows for patients who can get clot retrieval with thrombectomy or endovascular procedures up to 24 hours of last time known well. And even with that, they're having ongoing studies to see if we can even push these windows out even further past 24 hours. So it's a lot of good research trials going on now to see if we can help improve our patients and have less disability with stroke care. So first, I always have some at least introductory slides. This is one of the slides I give to my stroke with my nurses at Holy Cross Silver Spring lecture. So just a couple of faces here. Any faces familiar to you guys in regards to stars who've had strokes? All of them? Okay, so we have in the middle Luther Vandross. He, as you guys probably know, he yo-yoed up and down between weight loss and weight gain, and he had hypertension, diabetes, and he died only in his 50s, you know, due to a stroke. Brett Michaels, he actually had 2 hemorrhagic strokes, but doing fine and back singing. Nate Dogg, for those who know old school rap, not new school rap, I'm just putting it out there. The real rap. But he died, actually, he had a brainstem stroke. He had multiple strokes. He was only in his 40s. That fast lifestyle, he did have alcoholism, also issues. Luke Perry, 90210, he was only 52 and had a massive stroke. Now, I don't know if he had a hemorrhagic stroke or ischemic stroke. That wasn't disclosed in the news, but we know, unfortunately, it was massive. And then John Singletary, this past summer, died also of an unfortunate massive stroke due to sounds like uncontrolled hypertension. So just some stroke stats. Stroke is now the 5th leading cause of death. I think when I was here last time, it might have been still 3rd leading cause of death. I'm not sure. But now it's the 5th leading cause of death due to people taking better care of themselves, more awareness is out there to the community, and just healthcare all around improving. But it still is the leading cause of disability in the United States. Each year, 795,000 people are experiencing a stroke, and about 690,000 are new strokes each year, and about 140 deaths can be attributed to stroke each year. Those are new stats from the American Stroke Association that just came out this month. In the United States alone, a stroke occurs every 40 seconds, and every 4 minutes someone dies of a stroke. The stroke death rates actually has improved because, again, care overall has improved, and it has decreased to 28.7%. It used to be like in the 30s%. Now, women, we tend to have more risk for stroke than men as we get older because they say we still live longer, 55,000 annually. But women tend to die of a stroke and tend to have a greater disability when we do have strokes. African Americans have twice as more risk of having a stroke as compared to other ethnic groups, but the Hispanic population is getting right behind the African Americans actually with strokes. One of the care that I provide, I started a stroke discharge clinic at the Holy Cross Clinic sites in Georgia Avenue. And the majority of my stroke patients I see after discharge are the Hispanic population, and they're young. They're not, 60s, 70s, 80s. They are 30s, 40s, and 50s. The prediction, 3.4 million United States adults greater than 18 years old will have a stroke by 2030. That's only 11 years away. I have seen more stroke in the younger population in all ethnic groups, I would say, the past 5 years. Do y'all think why? Do y'all know why? Just guess. Energy drinks? I've had one stroke case like that had energy drinks.
Higher obesity rates?
Higher obesity rates, definitely. Anything else? People online even? Y'all can chime in this conversation. Don't be shy. I like an interactive audience. So
Untreated hypertension.
definitely. Getting hypertension much younger now because of the obesity rates, right? Childhood obesity definitely has increased. I had an 18-year-old had a stroke a couple of years back. Hypertension, obesity, new diabetic, type 2, high cholesterol of 300. They're now seeing, okay.
Adderall, some medications?
Adderall, I'm not honestly for sure. I know personally I've never seen a stroke case in that realm, but I would certainly have to look up that particular one. I can't, elaborate on that because I haven't had that experience with Adderall with presenting with stroke-like symptoms. But that's a good question. I will definitely look that up. What they are saying is that, I just lost my train of thought. I'm sorry. But with the 18-year-old, so what they're saying now, they're starting to actually see in the pediatric age group, especially around the teenager age, they're starting to see type 2 diabetes. When type 2 diabetes is always adult onset. So they're now seeing that in the pediatric population. Now with stroke costs, in 2015, according to American Heart, American Stroke, it's now $66.3 billion, but they anticipate it will continue to rise, especially with seeing more strokes in the younger age group of $143 billion by 2030. Now, as you guys already know, a stroke is defined as a sudden interruption of blood supply to the brain, whether it's due to a clot forming, causing occlusion in the blood vessel, or a blood vessel bursting. But if we don't stop this process, serious neurological deficits can occur. Not like the guy with the nails. I'm still amazed at that story. That's just crazy. So just a quick brief about how strokes can affect brain function. As you guys probably already know, you have the two hemispheres, the right and the left hemisphere. It's never, like I said, good to have a stroke, but what I have learned throughout my years of running the stroke program and taking care of stroke patients, when patients have right hemispheric stroke, they tend to have a better outcome compared to patients in the left hemisphere, but it also depends on the size of the stroke and where it's located, et cetera. But on the left hemisphere, I always call this the computer side of your brain because this is where your speech centers are and your reading and comprehension centers are. Also, it can affect movement on the right side of the body as well, and being able to understand, etc. On the right side of the brain, I always call that kind of your happier side, where But you can be more impulsive, especially like the right middle cerebral artery territory strokes. They can be very impulsive and very forgetful. Memory can also be impaired, and they could have weakness on the left side of the body. Now, this is just more of an FYI for you guys, but you know, when you guys come to the nursing homes or go to patient homes when they have questionable stroke-like symptoms, it's always good to know, okay, where is the stroke affected? Is the patient having a peripheral field deficit where their peripheral field is affected? Are they having an occipital lobe stroke? You know, are they having a frontal lobe stroke if they have like this flat, you know, effect? Or they're confused, or they're having memory deficits? Are they having slurred speech, or are they having aphasia? Parietal lobe, you know, I'm having numbness on one side. Is that my parietal lobe? Is the patient having a parietal lobe stroke, for example? I already talked about the occipital lobe. Insular, especially if the left hemisphere and it's in the insular cortex. Are they having aphasia? Are they having expressive aphasia or receptive aphasia? Are they able to recall, you know, short-term memory issues, for example? If they're having a stroke in the arterial cerebral artery, which lines your brain in this vicinity, you know, their leg will be weaker than their arm. If they have a posterior circulation stroke, typically you would be concerned about occipital lobe strokes and as well as brainstem strokes. Are they having double vision? Are they having blurred vision? In the temporal lobe, depending on which hemisphere, left or right side, they can have difficulty with speech. It could be slurred speech. It could be aphasia if it's the left hemisphere. Are they having a cerebellar stroke? A lot of the posterior circulation strokes with the brainstem and the cerebellums are hard to pick up. But if somebody says, okay, all of a sudden, I'm very dizzy. I might be having problems swallowing. I'm having blurred vision. I'm having double vision. Walking like they're drunk. Think that I might be actually having a brainstem stroke or a cerebellar stroke, because they also can present with nausea and vomiting too. And a lot of times when patients present with posterior circulation strokes, they said, well, it's a patient having a GI virus, because some of those symptoms accompany a GI virus, right? But typically, if it's a posterior circulation stroke and there's no diarrhea associated, think stroke until proven otherwise, especially if it's all of a sudden. In the middle cerebral artery strokes, those patients have a high, you know, stroke scale. When you guys bring the patient to us, we do what we call an NIH stroke scale. And the stroke scale can range from 0, meaning normal, or meaning least no deficits, or sometimes the posterior circulation strokes might have an NIH stroke scale of 0. That's why we still have to assess the patient. But it ranges from 0 to 42. And the higher your stroke scale, the bigger the stroke. So middle cerebral artery stroke patients typically have a higher stroke scale, definitely 15 and up. Those can be very detrimental strokes. Typically, the patient might have what we call like a gaze preference, where the eyes would deviate to the side of the lesion. They typically will have definitely weakness in both arm and leg. The leg might be worse. No, the arm might be worse than the leg, and depending on if it's in the left or right hemisphere, some speech abnormalities, neglect, etc. So it's 3 types of stroke. Ischemic stroke is the most common at 87%, hemorrhagic stroke 10%, and subarachnoid hemorrhage 3%. Now with stroke, despite of all social media, Facebook, Twitter, and Instagram, and the internet, etc., a lot of people still don't come into the hospital right away. You know, they'll lay down and say, oh, I'll be better in the morning, you know, or one patient told me, well, I didn't know numbness was a symptom of stroke. You know, you'd be surprised. I actually had an EMS person had a stroke a couple years ago at Holy Cross, and he just had numbness. And it's like, I think he also has some maybe facial droop, but it's very subtle. And we gave him TPA, and he did well and didn't even require rehab. He was able to go home and get back to his daily life. But all of a sudden, I'm having difficulty with speech, whether, like I said, a slurred speech or difficulty expressing yourself or difficulty understanding, difficulty walking, the worst headache of your life, decreased level of consciousness, numbness on one part or one side of the body, weakness on one part of one side of the body, sudden dizziness, vertigo. There's also stroke mimics out there, and I'm sure you guys have experienced that in the outside. But, you know, TIA, I just put it in this slide because a true TIA, the symptoms will last usually just within 10 to 15 minutes. If it lasts longer than that, most likely the MRI will show something with stroke. Because 50% of patients who present with TIAs usually can have changes on the MRI to show that they had a stroke. Have you ever heard about cerebral vein thrombosis? Have you ever heard of that type of stroke before? Well, I'm going to talk about a case. So stay tuned on that. Seizures can present like strokes, right? Because especially if it's a generalized seizure, and then they develop tau paralysis on one side. I had a 38-year-old who I saw in clinic yesterday. His stroke presentation was seizures. He had a left middle cerebral artery stroke. So he was outside the TPA window. So we transferred him to GW because his left middle cerebral artery was blocked off. We still don't know why he had a stroke. We're doing a workup as we speak, but all his workup so far is negative. He's Hispanic, bless you. He's Hispanic with no risk factors. No family history of stroke, no tobacco, drug, or alcohol abuse. 38 years old. So they did a thrombectomy. He's walking. He had a stroke July 16th. He came to me walking yesterday. You know, with left middle cerebral artery strokes, patients don't typically do well because that's the dominant hemisphere. But because he's young and early intervention as soon as possible helps save him not being as disabled as he could have been. He still has some aphasia issues, but I would anticipate he will continue to improve with that. Altered mental status. Sometime when we have patients present with altered mental status, excuse me, the workup shows the patient actually did have a stroke that caused the altered mental status. Complicated migraine can also be a mimic, especially if patient present with a hemiplegic migraine where they are definitely weak on one side. Their processing might be slow. Their speech might be slow. But when you do all the workup to rule in or rule out stroke, and the patient also complains of headache with their presentation, typically once the migraine is aborted, the symptoms resolve. Psychogenic, patients faking for gain, bless you, whether it's due because you want pain medicine. I had a couple of cases that one guy came and complained of abdominal pain, but also, I mean, he faked real good that he was having stroke-like symptoms. I mean, he could have won an Oscar. And we gave him TPA because you don't want to miss a stroke, right? Well, we got him in the ICU. He started demanding narcotics. And we was like, no, because you also have stomach history issues. We don't want to cause any bleeding, you know. So he walked out, left AMA. I don't get it, but you have patients that'll do that just to get the narcotics, for example. Hypoglycemia or even hyperglycemia can have stroke-like mimics. So that's why when we have patients that come in with stroke-like symptoms, we automatically do a blood sugar ASAP. Just make sure they're not hypo or either hyperglycememia. And Bell's palsy. Bell's palsy can definitely mimic and fool us in regards to stroke. Bell's palsy deals with, like, typically it's viral causes that causes issues with facial palsy with the cranial nerve 7. It also can involve cranial nerve 5, trigeminal, where the patient has also some numbness and paresthesias on the affected side. But typically they don't have any other stroke symptoms, and the brain imaging is usually negative. So BFAST, I'm sure you guys have heard about this, how FAST has now been changed over to BFAST. And the reason why that has changed is because even though American Heart, American Stroke won't change it yet. I'm not sure why. You know, I went to one of their conferences and I was like, why haven't y'all changed it? Well, we need to do further research studies to see if it's actually have shown more awareness in picking up more, especially the posterior circulation strokes with dealing with the brainstem and the cerebellum, or the occipital lobe strokes. So one day I guess they will. But the reason why it was changed from FAST to BFAST is to pick up those occipital lobe strokes that can be missed, because those can be disabling because you can't drive, okay? And so B is for balance, also to pick up those brainstem strokes, because sometimes brainstem strokes can be deadly. You know, patients can progress to being brain deaf. Patients can progress to being locked in. Have you ever heard of a locked-in syndrome at all? So locked-in syndrome is where a patient can hear you, but they can't communicate back to you. They can't move, but they understand exactly everything that you're saying to them. You may ask the patient on exam to see if they follow any commands, so you have the patient look up and down. They may be able to do that only, but that's it. I've had, unfortunately, cases where patients who came in with brainstem stroke evolved to being locked in, and we had to wind up doing trach and peg and sending them to long-term care, even as young as in their 40s and 50s, unfortunately. And then y'all know about FAST. Now, I wanted to bring this to you guys. I went to Washington Hospital Center had a stroke conference in May this year, and they shared about how can we identify strokes more earlier, even while the patient's in ambulance, looking for ischemia or impaired blood, brain blood flow. So they are doing currently research trials of using this volumetric integral phase shift spectroscopy, where it looks to see for any ischemia. They're also looking to use this Lucid M1 to look for any type of impaired cerebral blood flow, and then also using this alpha stroke device to look for any type of impaired blood flow with stroke. So stay tuned. You might see it in your ambulance. It's coming soon. I don't know. But they're looking at ways to how can we identify further sooner any type of stroke symptoms and impairment and ischemia.
So this is at the hospital center. Are they doing anything in DC with it? Or
I know in DC they are trialing some of these devices. I have not heard yet from Maryland, actually, but stay tuned. We don't have, a grant where we can have a CT scanner in the ambulance and, get everything done there. But, and just some highlights about future stroke care before we go into the case studies. They're also, like I said, looking to expand given TPA. But they currently are doing a research trial, it's called a timeless trial, where they'll use not Adaplase or TPA, they're using the other agent called tenactoplase or T-Encase, that they use for MI patients. Well, it's not yet FDA approved for stroke, but they're doing current research studies, and they have shown that for patients who may require doing a thrombectomy or endovascular device, given tenactoplase actually has better perfusion improvement when they do the thrombectomy. So stay tuned for that. But what they would do is IV push tenactoplase in the 4.5 to 24-hour window of last time seen normal, and then take the patient to the neuro IR suite where they would perform a thrombectomy for large vessel occlusion. They also are looking at doing endovascular treatment in children. When I went to, again, Washington Hospital Center Stroke Conference in May, they actually had done a couple of cases from patients from Children's Hospital, the GW, where children had large vessel occlusions. Using neuroprotective agents for patients who have this really bad atherosclerotic disease intracranially to see if that would help when they give the patient TPA or do a thrombectomy. Also for patients, EVT is endovascular treatment for large core strokes that is 100 ml, but their stroke scale is low. We have actually sent patients who had a stroke scale of less than 6 to a thrombectomy center because they did have a large vessel occlusion. And those patients actually did well, where they even went home and had outpatient rehab. But they are doing, ongoing research for that. And also looking at better reperfusion studies. We just had installed for our CT scanners what they call a rapid perfusion study. And it looks at the area infarcted as far as core for ischemic stroke. Hey. And penumbra, where that's the area at risk for where the stroke can further evolve to if we don't provide any interventions. And as I stated before, looking at extended that window for TPA and thrombectomy, ongoing trials are going on, so stay tuned. If I come back next time, hopefully I'll have some updates with some of these trials that's going on right now. And stem cells is still in the, discussion for stroke, but I haven't seen any recent research trials to be able to provide any addition. But stay tuned. Like I said, stroke care is definitely evolving. So I have about 5 cases for you guys today. So the first case was not a EMS case, but I thought it was important because this patient was only 21 years old. She actually was an in-house patient. So she was status post C-section. So on post-op day 2, patient developed aphasia and right-sided weakness. Now, the nurse had heard the baby crying, so she went into the room to assess the situation, and she noted the patient had stroke-like symptoms. So in hospitals, when patients have neural changes, they typically activate their STAT team, and then from there, the STAT team provider will assess the patient, and if deemed a stroke, then they'll activate the stroke team. So that's what happened with us. So given that we had established last time normal and established time of when the symptoms started, they had a discussion. Would you give a 21-year-old who just had a C-section, had a baby, TPA or not? Question that, we'll be concerned about bleeding, especially uterine bleeding, given she had a C-section. And also, would she be a candidate if she did have a large vessel occlusion for an endovascular procedure? So a head CT was done, and it showed a left middle cerebral artery hyperdense, meaning there's a clot in the left middle cerebral artery, and I'll show you the scan in a minute. So with discussion among OBGYN, neurology, and intensivists, they went ahead and decided to give TPA, which was given an extended window, meaning 3 to 4.5 hours, okay? So it took a little while because given she wasn't a straightforward case and they had to have the discussion with the mother, risks and benefits for everything, she eventually got it. So we looked up also the current 2018 guidelines before they were just actually updated this month, and just to see what the criteria, what they recommend in this type of patient scenario. And it states the safety and efficacy of IV Adaplase in early postpartum period, less than 14 days of delivery, have not been well established to be recommendation. This is her CT angiogram. And as you see here, this is where she has a block in the left middle cerebral artery. It should extend out to here. But it seems like it's like midway that she has an occlusion. This is her MRI. This white area is where she has a pretty large left middle cerebral ischemic stroke. And remember, this is a dominant hemisphere, and she's only 21 years old. You have to give her a chance, right? So this is her MRI after TPA. It's less ischemia, as you see here, which is good. So TPA definitely made a difference. And it opened up her left middle cerebral artery. So that's a good thing. This is her post TPA head CT. She did develop a little bit of hemorrhagic transformation, but it was mild and it did not worsen her neurological exam. So typically, you know, in 21-year-old, why would a healthy 21-year-old have a stroke? She had a healthy pregnancy, she had no issues, and she didn't have any issues until delivery. Apparently her cervix closed up. So that's why they had to do an emergency C-section. But otherwise, everything was fine, you know, during her pregnancy. And she was a healthy woman. So we did a hypercoagulable workup, because we already knew she was hypercoagulable for pregnancy perspective, but we went ahead and ordered the hypercoagulable workup. And it actually showed, surprisingly, she was positive for lupus anticoagulant. So we got hematology involved, and we went ahead and started anticoagulation 10 days out, because if you start anticoagulation sooner than that in a larger stroke, it can cause bleeding within that injured area of the brain. So she did, and we just had her on aspirin until her repeat HCT was stable. We actually discharged her to rehab. Her functional scale, which is called MRS, or Modified Rankin Scale, is a 3. So 6 is dead, 0 is patient back to normal, 3 and less is a good functional status to be in. So by the time she left us, she was back walking again, but she had definitely expressive aphasia. So she's back home, walking, able to talk, but she still has ongoing aphasia issues. She's been getting outpatient rehab, outpatient speech therapy for her ongoing aphasia. Any questions with that case? Okay. So our next case is a 64-year-old who presented with right-sided weakness while at work. So you guys brought him here to Holy Cross. His last time normal was 6 a.m. that he had seen talking with one of his coworkers. He has a history of hypertension, hyperlipidemia, and a smoker. His stroke scale was 18. His head CT showed a left MCA hyperdent sign at M2 segment, but no hemorrhage. TPA was started, and then we took him to to get a CTA, the head and neck done, to look for large vessel occlusion. And surprisingly, he actually looks like he had a left internal carotid artery occlusion and possibly collaterals. And I'll show you what I mean in a minute. So the patient was taken to the IR suite for thrombectomy within 6 hours of last time seen normal. His discharge NIH scale was 7. His modified Rankin was 4. Yes?
So for folks who don't know, can you just give a brief review of the NIH scale, the range, and what's good versus what's bad?
Right. So, like I said before, the NIH scale ranges from 0 to 42. The higher the NIH scale, the bigger the stroke. His stroke scale, like I said, was 18, so we already knew that he definitely probably had a medium to a large size stroke. Ideally, NIH scale is greater than 20, 25. It's not a good outcome. Sure. The patient was discharged to rehab. So this is the CT angiogram of the head and neck, looking at the larger blood vessels in the brain. This is your anterior cerebral arteries, right and left. When you're looking at brain films, it's opposite sides. So this is the right side, this is the left side. This is the middle cerebral artery here on the right. This is the internal carotid artery on the right. So on the right, looks normal, right? Something missing here? On the left? Obviously, right? Obviously. So it looks like his left internal carotid artery is occluded from here. And these are the collaterals, so these are the extra blood vessels that occurred over the years. So when I looked at that, I'm like, oh my God, he definitely has a big stroke. This is a clot that was removed. So that's a pretty big clot, right? This is his brain MRI, post TPA and thrombectomy. The white areas right here, the ischemia in the left middle cerebral artery territory and internal carotid territory. This stroke could have been way bigger if we hadn't intervened with this guy. This is the post-angial films. So the neurointerventionalist actually had to put a stent in this left carotid artery so he can get blood flow up to the brain. And then also he had to do a thrombectomy, so that's where he got the clot from that I showed you guys in the prior slide. But he was able to open up the left middle cerebral artery again. So he saved this man's life. Any questions on this case?
I can't really see that well from back here. Is that the stent that it looks like a mesh?
Yes.
Right at that Y?
Yes.
Okay.
Yes. That's the stent. So our next case, 23-year-old with a history of encephalitis and Crohn's disease since the age of 7, presented with altermental status. Per his brother, he had weakness for a week. He was unable to get up from the couch. He also was wearing eyeglasses for a week because of photophobia and headache. So the day before admission, he complained to his roommate about unable to feel his foot, unable to walk, and had to be carried by the roommate. He also had difficulty communicating. He had aphasia issues. So they brought him to the hospital. An MRI showed bilateral subarachnoid hemorrhage. His NIH stroke scale was 22. So prior to that, he was seen in our ED twice in December due to gross hematuria and dysuria. He also had altermental status at that time as well, but no head imaging was done. They attributed his altermental status probably was due to a urinary tract infection, and they gave him antibiotics and sent him home. Additional history, a history of marijuana, opiate abuse, recent heroin abuse, and he unfortunately had lost his father. His father unfortunately had committed suicide. He also had a very dysfunctional family, so it was challenging. And he stayed in the hospital for 51 days. So given his brain films, and I'll show y'all that in a minute, because he had a lot of brain swelling, we had to start 3% saline, which is a concentrated saline, to help control cerebral edema so the patient wouldn't herniate. And we also had to give him mannitol as well. We also consulted our neurosurgery team because he might require where they would do a hemicraniectomy. And what that is where they'll take a piece of the skull off to be able to have the brain to further expand out from the cerebral edema so he wouldn't herniate. And then we also, at the time when we had our neuro-IR person, you know, we were contemplating on giving his sagittal thrombosis. Would he require a thrombectomy where they would like insert TPA, IV, well, intraarterial TPA to break out, well, dislodge the clot to get more blood flow. But he was a very challenging case. I learned a lot from this case. He also, because of his decreased mental status, we had to intubate him, but we were able to eventually extubate him. He didn't require a trach. So, given his history in this presentation, etc., they did treat him for meningitis. Again, he did have bilateral strokes with hemorrhagic transformation. He had his strokes were more involved in the left hemisphere than the right hemisphere. And due to the subarachnoid hemorrhage component of his lesions, they decided with no thrombectomy or TPA lysis. So, with further imaging, it showed that he had a sagittal and left transverse thrombosis, and I'll explain that. And when patients have what we call a cerebral vein thrombosis, which is a rare other type of stroke, this is the only stroke that you can give that may have a hemorrhagic component where you need to give them anticoagulation. So we started that, heparin IV and Coumadin, but that was also challenging because he has a history of ulcerative colitis. So every time we started anticoagulation, he started having bloody stools. So we just had to work on the different dosing so he wouldn't have further bloody stools. We also had started steroids because of his ulcerative colitis, and we also had to give him blood transfusions with his bloody stools due to his anemia. He also, unfortunately, developed C. difficile, which is an infection of the gut, and a UTI, so we had to treat that. And then, given this chronic pain issues with this young gentleman, we had to get pain management involved to help control his pain issues as well. So this is his, what we call a MR venogram that looks at the sinuses in the brain. I'm not talking about the sinuses who makes us sneeze and makes us miserable during the change of seasons. These are the sinuses that circulate the cerebral spinal fluid and blood throughout the brain. And if these are blocked off, it can cause intracranial pressure, and it can cause oozing of those smaller veins that can cause bleeding. So you can have either ischemia or bleeding when patients have a thrombosis in their sinuses here. So this is a sagittal sinus, so clearly it's supposed to extend up to the frontal area, and clearly it's blocked off here. You also have cortical sinuses that definitely, he should have more cortical sinuses that were also blocked off. And then this is a transfer sinus. This is the right transfer sinus, and obviously the left transfer sinus is occluded. This is a normal picture of how your sinuses should be, okay? So clearly, if you compare it, compared to his scan, he has a lot of sinuses blocked off, okay? So this is his head CT. You see definitely the left hemisphere is almost pretty much infarcted with ischemia, and then there's right ischemic areas. This is the MRI that showed, again, ischemia in the white areas, left and right. And this is the other aspect of MRI that looks for blood. These darker areas is where he had hemorrhagic transformation. So, given this gentleman history, we had to find out why he had these strokes. So, drug use is, always a risk factor for strokes. He also, with the hypercoagulable workup, he had a protein C deficiency that can make you more at risk for stroke. Hypercoagulable state, was he at increased risk of blood clots due to his ulcerative colitis? So we had to do some research. So what I could find is that according to neurology in 1978 and up to date in 2016, with ulcerative colitis, it says systemic arterial and venous thromboembolic complications occur often in ulcerative colitis, but stroke is uncommon. Abnormalities in early stages of clotting may be responsible, and the risk of thromboembolic phenomenon in young patients seems to increase with exacerbations of this form of chronic inflammatory bowel disease. So like I said, I learned a lot from this case. I'm sure with his strokes, it's probably multifactorial reasons because he certainly had it, but I didn't know that ulcerative colitis could also be a risk factor for stroke. And his outcome, so the palliative care nurse had called me and she said, Sharon, a patient is calling for you, he wants to see you, because we were planning now for rehab placement. So I went into the room, I said, hi, so-and-so, how you doing? And he said, I want to make sure my pain medicine goes with me to rehab. And I said, don't worry, you will have your pain medication. And I said, oh, it's time for you to go. For him, asking for his pain medicine. But by the time he left us, actually, he was able to move both of his arms and legs. He was still weak, but he was able to at least move them. He was able to transfer from bed to chair. He was actually speaking pretty well, still had some expressive aphasia. He was actually ordering his meals He came a long way. So we saved this young gentleman's life. So we followed up with his mother to see how he was doing, and she shared a video, him playing arcade games and walking. And she had said that his aphasia is about 90% resolved. So this is why we do what we do, to make a difference in people's lives.
With this history of heroin abuse, what type of conversation was had about the type of pain management he was given?
So we let the pain management department take care of that piece. I know for myself, when the nurses came to me to ask about, what pain medicine to give, I was very selective on trying to first use non-narcotic, agents. And I would lean to the pain management people to see what cocktail we can use to help control his pain. But we always try to first do the non-narcotics. Given his chronic use, we did want to give him narcotics, but we spaced it out. And, when he asked, we just tried, all different remedies so he wouldn't use more than was recommended. So.
What did they want to hear?
It was, I want to say, MS Contin, and this has been about a couple of years now. I think it was MS Contin and oxycodone. So they had short-term pain medicine, PRN, and longer-term pain medicine twice a day. So that seemed to work for him. And he, like I said, he's back eating, etc. Next case study is a 28-year-old, a typo there, who presented with automental status. She was found down at a metro station and brought to Holy Cross Hospital for further evaluation. She was noted with left-sided weakness. Her HCT revealed a large right hemispheric intracerebral hemorrhage. While in ED, she developed worsening of her mental status, and they had to give her, again, 3% saline to control her cerebral edema, as well as mannitol. And they required to intubate her and hyperventilate her because she actually had started to herniate in her brain. And then they took her to, emergently to the operating room for a right hemicraniectomy. And they also had to put a external ventricular drain in to help drain the blood outside the brain. So she has no past medical history, healthy young woman, had an 8-year-old son, and she unfortunately had recently had lost her father. A cerebral angiogram was done to look at the blood vessels in the brain and actually showed an AVM. Are y'all familiar with AVM? Atriovenous malformation? I see some nods. I'll explain more. So this is her HCT on admission. As you see, obviously, this is the blood. The white area right here with the laser, this is where a blood vessel bursts in her brain and caused bleeding into her brain. She also has shifting already to the left side of the brain. And right here, she has bleeding that traveled from interparenchymally into her ventricles. She actually just smushed pretty much the right lateral ventricle. This is the left one that also is small. So after the craniectomy, so what that involves is that they take off the skull, okay? So this is missing. They put the skull in your abdomen, or they can also put it in the lab in the freezer. But I'll just put it in the abdominal area until the brain swelling resolves, and then they can take it out the abdomen and replace it back to the brain, to the skull, excuse me. So as you see, if this intervention was not done, the patient certainly could have herniated and died. So with doing the medical management, but also surgical management, the shifting did improve some. The blood did seem like also expanded a little bit with her bleed. So this is an angiogram that's done in the IR suite, neuro IR suite, And if you notice this kind of mesh of blood vessels here, this is a atrial venous malformation. I'll explain that in a minute. You can all, oh, thanks, Linda. Can you see it better now? Okay, so this mesh of spaghetti. So atrial venous malformation, basically, this is your normal capillary bed, okay? So you have artery and capillaries and veins. But when people have atrial venous malformations, they're missing the capillary bed. They have an artery bed and they have a venous, but they don't have the capillary. And because of that, it can form this abnormality here. And what can happen is that aneurysms can form and burst and cause bleeding to the brain. This is majority of the time something that you're born with and you don't know that you have it until you start having stroke symptoms or headaches. So what happens with patients who have that, when they took her to the new IR suite, they attempted to embolize as much as possible using a catheter, as you see here. I'll call it a glue gun. But taking this catheter with onyx glue that smells like rotten egg, it would smell up the whole unit. And they would glue as much as possible these, vessels so they won't form into aneurysms and rupture and cause bleeding to the brain. So her outcome, she wound up getting feeder tube and peg. She was transferred to rehab. She was pretty disabled at a functional scale, modified ranking scale of 5. I unfortunately don't know how she's doing now. But she would have to come back. Typically, patients can come back within 3 to 6 months for a cranioplasty, where they would take the skull and put it back once, like I said, the brain swelling goes completely down. And our last case is a 40-year-old gentleman with no past medical history, healthy guy, who presented to us with altermental status. So per EMS, the patient was agitated and altered overnight, per the family. He was knocking things over and just seemed to be confused. The family was able to get him to sleep on the couch, but the morning when they checked on him, he seemed more confused, so they called EMS. So the patient beforehand had went to his primary care physician earlier that week for headaches and eye complaints, and was sent home on antibiotics. So on arrival, because of his altermental status and the GCS of 7, they intubated him. They did a head CT that showed a large left frontal temporal hematoma with mass effect, and that's just swelling with a shift. So neurosurgery was contacted right away. He also had signs of herniation besides his altermental status. His left pupil was fixed and dilated. That's the sign of herniation. That's not good. So he had an ICH score of 2, and what basically that means is that it looks at the patient mortality within 30 days, but that's a lower ICH score, so that part was good. So they once they intubated him, they give mannitol because, again, he was showing active signs of herniation. And they hyperventilated him, elevated his head to bed for intracranial pressure control. And they took emergency to OR for a craniectomy. And they also had to put an extraventricular drain to drain out the blood from the ventricles. So this is his head CT. As you see, can y'all see this, or do you need me to dim down the lights? Can y'all see this okay? Okay. So again, eyes and nose, right side, left side, back of the brain, ruptured blood vessel causing bleeding into the left side. So his hospitalization course was complicated by an acute occipital infarction that caused right upper extremity weakness and loss of dexterity after he had a cerebral angiogram. So the cerebral angiogram had revealed that he had a left dural AV fistula, and I'll talk about that in a minute, with a P4, and that's a branch off your posterior cerebral artery. And they were not able to, well, they did not embolize it using the glue gun I showed you in the prior picture. So the hospitalization was complicated by infection. The patient has staph epidermidis in the cerebrospinal fluid because he had the external ventricular drain that's in his brain. He also developed bacteremia, also ventilator-associated pneumonia, and tracheitis because we wound up having to do a trach and peg in this guy. But eventually he was able to be weaned off the vent. He did require, like I say, a peg, a feeding tube in his stomach. And he was then discharged to rehab. And in rehab, they were able to remove his trach. Eventually, his drain was able to be removed because they were concerned about if he was going to require a shunt in his brain. But thankfully, he did not require that. He also, during this hospitalization, developed deep vein thrombosis. But we could not anticoagulate him because of the hemorrhagic stroke. So he was brought back for another cerebral angiogram to evaluate. And apparently, they did embolize him when he went the first time. But they didn't see any other vessels that they needed to embolize at that time. And they were concerned, well, maybe this was not a dural AV fistula, maybe this was a cerebral vein thrombosis. So they said he'd probably need anticoagulation if that was the case. He came back 2 months later for a cranioplasty where they put the skull back on his brain, and he had developed a seizure afterwards, but he did well. So this is his HCT post-op, again, where they did the decompressive craniectomy and removed part of his skull. As you see, he's already has started having the blood reabsorb, which is a good thing. Now, with patients with dural AV fistulas, they develop this abnormal vasculature, and they have this draining vein here. But again, doing this abnormal mesh of blood vessels, it can cause bleeding with rupture of these vessels. This is a cranioplasty picture of cranioplasty. This is not him, but just give you kind of a picture of what I'm talking about. So this is when they remove the scalp and it's a bone flap, and what happens when they put the part of the skull back. So he was in the hospital for 34 days. He had a ranking scale of 4. He went to acute rehab, and then in the post-op visit, he actually walked into the physician's office and was talking and doing really well. He actually came back to visit us to just say thank you, and he looked so good. He looked so good. So he did well. So I don't know if I have, Linda ran out the room 10 o'clock. If y'all want, I can be happy to show you guys some videos of thrombectomy, different devices that they use for ischemic stroke. I'll wait for Linda to come back, but I'll go ahead and at least pull up. Hopefully this works. Yes. Oh, Lord. Will it still let me do it? Let's see. Any questions so far? Can y'all see this okay? Now, this unfortunately doesn't have sound. So when you guys bring us patients with ischemic stroke that may have a large vessel occlusion, and when we do our studies, the patient has a large vessel occlusion, then we will send the patient to the appropriate center that can perform these procedures. And this is one of the devices that they would use to remove the clot that's causing havoc. So this is the penumbra device, and basically they use this suction type of device to suck out the clot that's occluding the blood vessels. Now, I'm sorry, this one doesn't have sound, but you clearly can see the video. And when these procedures are done, you know, more and more studies have shown that because of the advance in the devices, we've had more successes with thrombectomy cases. Let me know when you want me to stop. Okay. Okay, all right. I think I have to have just 2 more videos, actually.
So,
Now this one does have sound, but I'm going to advance some of this.
Clots can form in the heart or any arteries.
I'm
due to
sorry, is that
various
too
causes.
loud?
A clot formed elsewhere
Where's
is
the
called a
volume?
thrombus, and it can break
Oh,
loose
here.
and begin traveling down the artery with blood flow. Now it is called an embolus.
Can y'all hear this
Sometimes
okay?
the blood flow will lead it to the brain, or
Yeah.
it can block one of
Okay.
the arteries that is supplying
This
the
is the
brain with
Trevo
blood.
stent.
When this occurs, it's called an acute ischemic stroke. To clear the blockage and restore blood flow to the brain, a physician may use a clot retrieval device, such as the new Trevo ProView Retriever, the first fully visible stent retriever specifically designed for stroke intervention. Using a balloon guide catheter and with the aid of a suitable guide wire, the microcatheter is advanced through the occlusion and positioned distal to the clot for accurate deployment. The guide wire is then removed, and with the aid of fluoroscopic imaging, the Trevo ProView Retriever is carefully advanced up through the microcatheter. Trevo ProView is visible under fluoroscopy for accurate placement and observable stroke behavior. After positioning and unsheathing Trevo, allow time for maximum clot integration. With its vertical strut orientation and tailored radial strength, the Trevo ProView Retriever is engineered specifically for efficient clot integration. In addition, Trevo's tubular stent trigger design and spiral cell alignment conform to the vessel with uniform cell area and no cell overlap. Enhanced conformability promotes excellent clot integration regardless of tortuosity. Prior to retraction, the balloon guide catheter is inflated to occlude flow. The Trevo ProView Retriever and microcatheter are then pulled down as a unit while slowly aspirating through the balloon guide catheter. Vigorous aspiration is started through the balloon guide catheter as Trevo and the microcatheter are removed, and full revascularization is verified. In treating a stroke and restoring blood flow to the brain, time is.
Let me see this one work. If not, yeah. Oh, I'm so sorry. Okay, but the other video that didn't play is a solitaire device. So it's the same kind of stent retriever as you saw previously, and that's the most common device that they use for patients with ischemic stroke and large vessel occlusion to do an endovascular procedure. But thank you guys for your time. Any questions? Yes. Okay. Yes.
Were any of the ones brought in by EMS like identified as a stroke alert?
Yes, they were. Yes, they were.
All
Yes.
of them, right?
All of them. Yes, which is good.
So there was a research protocol in the city of Baltimore.
Yes.
Where they had a LAM score of 4 or 5. They would
Yes.
be required to bring them to a comprehensive stroke center
Yes.
within 30 minutes.
Yes.
Are they considering doing that here? Because I know we have a comprehensive stroke center within 30 minutes from like the Silver Spring area. So.
Right. Well, the update with that, and I'm glad actually you brought that up. The update with that, they're going to extend the research trial, and they're going to include Sinai Hospital and I think some other Eastern hospitals for that research trial. Will it affect us in the future? I'm not sure yet, you know, because the guidelines recommend that if you're able to transfer a patient who has large vessel occlusion or a LAM score 4 or higher, and it's not beyond, I think, believe 15 or 30 minutes, you can consider transfer. But, you know, the goal is if the patient's a TPA candidate, you want to start TPA ASAP. And then from there, if they need a thrombectomy, you know, get them to the appropriate place or perform it if the hospital is able to perform it. So stay tuned. But the trial has been in Baltimore County extended. And I want to say they were supposed to start either this fall or either early part of next year. But we actually have a meeting actually next Friday, so we'll probably get updated about that. So it may change. It may change how we do. So stay tuned.
Can you guys do the thrombectomies around the clock, or is it just like a Monday through Friday when the neurologist is in the hospital?
So for Holy Cross Hospital, Silver Spring, and Germantown, we send out patients. We have the capability at Silver Spring, but we don't have the neuro-IR coverage right now. So our process is we give TPA ASAP and transfer out ASAP for thrombectomy. Yes.
Where do you usually send them?
So we have contracts with GW, we have contracts with University of Maryland, we've sent patients to Suburban Hospital, so whoever can take the patient ASAP, we send them to. So you have Suburban, University of Maryland, Johns Hopkins Bayview, Sinai, Washington Hospital Center, GW, Georgetown. Those are all comprehensive or thrombectomy ready capable centers that we would transfer our patients to.
Two questions from online. The first was, had an ED physician ask the provider whether or not aspirin was given? So if you want to elaborate a little bit on that.
For which case? For the TPA case or?
A patient he or she brought into the ER,
Uh-huh.
the ER physician asked if the provider had given aspirin to the patient.
Mm-hmm. I mean, that is a common question they may ask. Would it change for at least ischemic stroke the decision management for giving TPA? No.
So just a general question then.
Uh-huh. But yeah.
And, the second question is, have you seen a lot, so recently we've added visual disturbances to our protocol.
Yes.
Have you caught strokes based on that?
Yes, definitely. Definitely. Recently, we had a patient who presented with just a really bad headache and peripheral field deficit. And the ED physician thought the patient had a retinal artery occlusion, which certainly can happen. But when we examined the patient, it showed that the patient clearly had what we call, like I said, a hemianopsia or peripheral field deficit. And I asked the ED physician, don't transfer. Let's do a stat MRI. And the MRI picked up that he had occipital lobe stroke. So yes, you can pick him up easier that way, yes. Now, we couldn't give him TPA because he was on Xarelto.
Any other questions? Thank you very much, Sharon.
Thank you all. Thank you.
We're going to take like 5 to 10 minutes, so if you want to get up and stretch for a minute while we get the next presenter up. We'll be back in a few.
Also, I had some
We had Sharon from Holy Cross, and now we have Dr. Adil from Suburban. And Mary Jo Rucker is their stroke nurse coordinator, and she's going to introduce him. We have some handouts at the table when you go to log out on the tablets. If you would like to take anything, some little things to hang on your ID for Be Fast and some magnets. And Sharon brought some Madapins.
Yes,
Right,
the
some
ischemic stroke.
ischemic stroke spiral little notebooks for you. So feel free to take them on your way out. And turn this over to our stroke team from Suburban now. We had Holy Cross, now we have Suburban.
Hi,
Johns Hopkins Suburban. Sorry.
I am Jo. I am the stroke
That's an important name.
program manager at Suburban Hospital. Hopefully some of you, if you've brought a patient to Suburban and you're interested in coming into the MRI, I let you come in and explain to you what's going on. We have a new medical director this year, and his name is Dr. Adil. He was a fellow at Suburban with the National Institute of Health program that we are collaborating with, and he is now our new medical director.
Thank you so much. Good morning, everyone. Thank you for inviting us and providing this opportunity to present our program. I really wanted to thank you, Shannon, for presenting a great cases and help me prepare this. it will be helpful for me. So quickly, let me talk a little bit about Suburban Hospital history. The Suburban Hospital basically was opened in 1943, and in 1998 there was no stroke team at Suburban Hospital. In 1999, we started collaborating with the National Institute of Neurological Disorder, which is one of the institute at NIH, National Institute of Health. And in 2000, really, we started, we had a stroke team initiated within like 24/7. So it's a pretty old program now, almost like 19 years of collaboration with NIH. We started a prospective registry, which is a very important aspect of our program, that all the stroke patients that presented to ED and admitted to our stroke service, we collected data, and we're doing a lot of studies in that I'm going to talk about in my presentation. We received a Joint Commission certification as a primary stroke center in 2005. We received a state certification in 2007. And in 2008, we started collaborating with NIH, and they started a vascular neurology fellowship, which is a stroke fellowship. So you do a 4 years of neurology residency, and after that, it's a 1-year dedicated fellowship where you only see stroke patients and then basically become a stroke expert after your primary neurology residency. From 2013 until 2019, we are a Gold Plus award by American Heart Association. And during this 19 years, we have published more than 200 publications in collaboration with NIH. So these three basic aim and objectives of our program is basically we have a very unique collaboration with NIH, National Institute of Health, and it is unique because we know all the new trials and emerging new techniques is basically either it's funded by National Institute of Health or either actually the trial was happening at NIH and Suburban was one of the enrolling sites. The other is basically to provide a state-of-the-art stroke care, and our stroke service is 24-hour. We provide all interventions starting TPA and all the way to the IR 24/7. So this is again very unique that it's a community hospital, just a little bit over 300 bed, but we function at an academic level because we have this IR coverage for 24/7. Now this is how our stroke team work. So stroke care is basically a multidisciplinary approach. There are multiple departments are involved in stroke care. So let's see here, the patient, you guys bring patient to ED, nursing staff is involved, and radiology is now, it's basically a key part of our stroke program, because in all new trials, imaging is very important, and then you select patient based on their imaging findings. So we educate our MRI and CT technicians to understand the time is brain and how imaging is important. So basically, they really understand the stroke care and their role in stroke management. Then stroke team comes in, and then IR, of course, if there is a large vessel occlusion, as Shannon presented a lot of cases, if there is occlusion, and I'll talk about the large vessel occlusion a little bit. Then hospitalist is involved. They admit basically patients. Then if the patient received TPA or IR, they go to the ICU, and then after the ICU care, we step down our patient to PCU, which is progressive care unit. And this is a very, very special unit because every single nurse is basically trained on stroke management. After this, again, it's a physical therapy, occupational therapy, speech and rehab, and social worker, and then quality department. Quality is very important at this point because after the patient is discharged, we go back and look at the encounter and try to make sure that we have delivered the care that was appropriate for that patient. And then based on this data, this gives an opportunity to improve our service. So now, a couple of slides on why we are unique, why our program is a little bit different than other programs. So in the state of Maryland, and one of the few in the world, actually, we are MRI-based triage. So when patient comes to the ED, we do MRI at presentation instead of CT scan. And why is that? I will explain in the next couple of slides. But just keep in mind that our first screening imaging modality is MRI, and it's not CT scan. And it's the only hospital in the state of Maryland, and it's one of the few hospitals in the world that does basically MRI on triage. Another unique aspect is we have a vascular neurologist coverage 24/7. So every single physician on a stroke service is a stroke trained. As I said, like after 4 years of neurology residency, it's a 1 year of stroke dedicated training. So our service is basically covered by vascular neurologists 24/7. We have a resident and fellows. The voluntary resident basically rotate with us almost 7 to 8 months a year. And then we have an NIH fellow, and I was a fellow. And as Mary Jo was mentioning, that I'm trained at Suburban and a couple of other hospitals through NIH. And a multiple research study. So if you look at this, considering that it's a small community hospital, we do everything that any big academic center does for stroke care. We do MRI, we have a vascular neurologist coverage for 24/7, we have a resident and fellows, and we do a lot of research. As I said, we have published more than 200 papers so far. Now, I wanted to spend most of the time on this, why MRI when CT is faster. So first thing is early stroke detection. I mean, this is true for any disease, like early detection, you start the management early, the outcome is better. Now, the issue with CT scan is when you do CT scan, CT takes almost sometimes 4 hours, 4 to 12 hours to show up a stroke on imaging. In first 6 hours, CT will be negative even if there is a stroke happening, right? And with MRI, you can actually see a stroke within few minutes. Like you saw a patient with a stroke-like symptoms, right-sided weakness or the vision changes, and you did MRI within 5 minutes. MRI will show you can pick up a stroke ischemia on MRI, so which is a big thing. So let's let's take these two scenarios. Patients with a stroke symptom, you did a CT scan, CT showed no stroke, right? But you're suspecting a stroke. So now that you're suspecting a stroke, you will give this patient TPA. Now, whether this patient had a stroke or not, you don't know at this point. You're suspecting, right? Because you have not seen it on the imaging. Does that make sense? Next is, I'm sorry. So the next scenario is patient with a stroke symptom. You did MRI. MRI showed no stroke. Now you know within 5 minutes, 10 minutes, or 15 minutes that it's not a stroke. So you're not going to give TPA because likely this is a stroke mimic. Now let me explain what is a stroke mimic. So there are many other neurological conditions that can present with stroke-like symptoms, like migraine, complex migraine, seizure, electrolyte imbalance, some kind of a conversion disorder, and many other psychiatric disorders can present with exactly same stroke-like symptoms, and this is basically called stroke mimics. In clinical trials, they have reported that 10 to 13% of patients presented to ED is basically stroke mimics, which means if you're doing a CT scan, out of 100 patients, 13 patients are getting TPA, but no stroke. Now, this is reported in the clinical trial, and the clinical trial is a very controlled situation when everyone is on top of the patient care, a lot of coordinators, and timing is very, very, very tight. In a real world, this is somewhat around 15 to 20%. So this is what I wanted to explain, that MRI, you treat what you see. If you don't treat, if you don't see a stroke, you don't treat. So that's a big thing, that you're saving a lot of money. So TPA costs like $7,000 to $10,000. So just imagine, like if you're giving 15 TPA out of 100 when there's no stroke, that's almost like $150,000. And then just imagine how many people having a stroke in a year. So how much money you can save just by doing MRI at presentation. There are some challenges that I'm going to talk about why MRI is not feasible for every stroke center. Now, and then other thing is no radiation. So in CT, there's a lot of radiation. MRI is basically a huge magnet, and it uses a magnetic field, and then you can pick early changes like ischemia or stroke on MRI. Does that make sense? Any questions here? Okay. Now, the other thing I want to talk about MRI is when you do CT scan, you just had one sequence. You just have to see whether there's a bleed or not. If there is no bleed, you push TPA. MRI takes a little bit more time, but it has a number of sequences. I don't want to go into detail of these sequences. This is beyond the spectrum of this lecture, but we get a lot more information, and based on all these sequences, like this DWI sequence, diffusion weighted imaging, ADC, FLAIR, GRE, perfusion, and MRA, we can actually age the stroke. We can tell by looking at these sequences whether this stroke onset was within 6-hour window, within 4.5 hours, a week ago, 2 weeks ago, or a month ago. So you can literally age the stroke based on these sequences. With CT, it's difficult because stroke starts showing up on CT, as I said, after 4 hours, and some people after 6 hours. So you're really missing the early period. You just see the CT scan is negative, there's no bleed, and you just treat. So this is another advantage of MRI. Now the question is door to needle time. So MRI, our protocol is 12 minutes. We can have all these sequences within 12 minutes. There are a few centers you can have these sequences in 7 or 8 minutes, but we do a lot of research, so that's why it's 12 minutes. And we have demonstrated and published this article in Neurology that you can easily treat the patients under 60 minutes by using MRI, because there's a lot of debate going on in the community and in the societies that when you do MRI, it takes more time, and it's hard to treat a patient in less than 60 minutes. That's not true. We are doing this for last almost like 17 to 18 years, and our door-to-needle time is pretty good. Okay, the other important thing that I want to talk about MRI, which is not possible if you do CT scan. So when you're in the field, you know there are some strokes which are witnessed and some of them are unwitnessed, which means that you're in the field and the family tells you that the patient started having symptoms 2 hours ago, 3 hours ago, 4 hours ago, but many times they don't know, they don't have the timing when the symptoms start, patient found down or anything else, which means this is an unwitnessed stroke. And this is basically approximately 25 to 30% of patients. So all patients, the stroke-like symptoms present to ED, 25 to 30% of patients are unwitnessed where you don't have the timing. So based on the AHA, American Heart Association criteria, if you don't know the timing, you will not treat this patient. These patients will be excluded from any intervention because you don't have a timing and the risk of bleeding is very high. So again, if you have MRI and if you have all those sequences and you don't have the timing, you can actually tell that the stroke onset is within 4.5-hour window, and then you can treat that patient. And using that technique, it increases the TPA utilization. Now, you see this here. This is a patient with DWI, this hyperintensity, this bright area. This is a stroke. But this is flare. This is another sequence. You don't see anything here, which means that this is early, and the stroke started and the stroke symptoms started, or the stroke onset is within 4.5-hour window, and it is safe to treat with IV TPA. So this is the trial that basically published in 2018, and Suburban Hospital was one of the enrollment sites. So this trial was done at only three hospitals. One was Suburban Hospital, one was Hospital Center, and one hospital in Texas and at Harvard. So there were like 4 hospitals. They did this trial. They recruited 80 patients, and this paper was published in Annals of Neurology. And now the new recent ischemic stroke guidelines just published like last week, 2019, and now this is a standard of care. But Suburban Hospital is practicing this since 2012. So just by using MRI, number one, we will treat unwitnessed stroke patients which we were not treating if you take these patients to MRI. So I did this project and I presented to a European stroke conference that by using an MRI and treating unwitnessed stroke patients, you increase TPA utilization by 5.6% and prevent disability. So 5.6% means if 1 million patients having a stroke a year, just imagine how many patients you're treating, which were basically excluded if they go to the CT, if they go to the centers where you do a CT scan. Do you have a question?
Someone online asked you can go back. It's probably like 2 screens now. There's something I think they have a question about.
Sorry, say it again.
Go back 2 more screens. So not the previous one, but the one before.
This one?
Let's find out. I'm sorry, Dr. Unproceed, they're not answering back, so.
Okay. We can come back. Okay. Any questions about this? And then this include a wake-up stroke also. Again, this is a very common presentation that you're on the field and they said like patient basically just woke up with stroke symptoms. So again, with wake-up stroke, we don't have the timing. What is the last known normal? When did the symptoms started? So in wake-up patients, again, if you do an MRI and you found these findings that the flare is negative and DWI is positive, you can treat this patient. So this is the TPA utilization as Suburban. So just see there's like 1998, we were the treatment rate was 1.5. In 2001, it's 19%. In 2017, 20%. So I'm not aware of any other primary stroke center treatment rate is 20%. And this is just because we were practicing wake-up stroke, we were practicing MR witness, and that's why our treatment rate is pretty high. Now, let me talk about quickly a little bit of the timing, because there are new guidelines, and timings is very important, because when you're in the field, this is the most important data that you want to pay attention, whether this patient is a treatment candidate or not. So IV TPA, we do it 24/7, and we know that time is brain. Early treatment, better the outcome. Late treatment, worse the outcome. So for TPA, the rule is pretty simple. Any patients with stroke symptom presents within a treatment window, you give TPA. It doesn't matter whether it's a large vessel occlusion, it's a small or large. You just treat with TPA. It's pretty simple. But let's have a look of this timing. So previously, if the last known normal is less than 4.5 hours, this patient is a TPA candidate. And this is based on the NINDS trial that was done in 1995. Anyone with more than last known normal of 4.5 hours was excluded from this intervention. Now, based on MR witness and wake up, the last known normal cutoff is less than 24 hours. And this is not for thrombectomy. I'm talking about IV TPA. And symptom onset is less than 4.5 hours. So do you all understand the difference between the last known normal and symptom onset? Does everyone understand that part? Because this is important, that if the patient, for example, grandma was normal in the morning at 8 a.m., and you left a grandmother like at 8 a.m., and then you came back at 6 p.m., and you noticed that there's a facial weakness, there's a right-sided weakness, slurring of speech at 6, and you took a grandma to ED at 8 p.m. So your last known normal, what is your last known normal? Last known normal is 8 a.m. because that's the time when you saw that the grandmother was normal. And the symptom discovery, when you noticed that grandmother had stroke symptoms, that was at 6 p.m. and presented to ED at 8, which means just 2 hours within symptom onset. But we exactly don't know when the symptoms started. Symptoms started at 10 a.m., symptoms started at noon, symptoms started at 6, we don't know. It's just the symptom discovery, right? So we are 2 hours from symptom discovery, and within 24 hours of last known normal. This patient will not get treatment if you put this patient in a CT scan. As I said, this last known normal is more than 4.5 hours. If you do MRI, and again, if the DWI sequence is positive and FLAIR is negative, then you can say that the symptoms started somewhere around 3:30 or 4, within 4.5 hours of a symptom onset. And then you can treat this patient. Does that make sense, the concept of last known normal and symptom discovery? I'll be happy to explain one more time because this is important. And similarly is the case with wake up. So just remember that the window is 24 hours. It's extended. If the last known normal is within 24 hours, this patient still can be a candidate for IV TPA. Okay? Now let's talk about thrombectomy, and Shannon did a good job of explaining the large vessel occlusion. So basically, these are the patients. There's a big clot sitting in large vessel, and large vessel mean either this artery, which is internal carotid artery, either this one, which is middle cerebral artery, and you see that there is a cut here. You see a lot of vessels and blood flow in this area, but you don't see a blood flow in this area, and this is large vessel occlusion, right? Now, this is based on the imaging. But my question is, like, when you're in the field, how are you going to recognize whether this is a large vessel occlusion or not? Because recognition is important. If you recognize in the field that this is large vessel occlusion, then you will think that this patient needs to go to the place that can perform intervention or IR, not only TPA, right? By no means I'm not saying that transfer all patients to Suburban Hospital. I'm just saying that take them to the closest hospital where they can perform IR. So let's talk about a little bit when to suspect large vessel occlusion. I want to ask a question, if anyone can answer. How do you recognize that there, or maybe you suspect this could be a large vessel occlusion in the field? Anybody have an idea?
Is it a higher LAM score?
Higher LAM score, okay. Anything else? Okay, so this is very important. Let's talk about it. So to my understanding, you all use the Cincinnati pre-hospital stroke scale and Los Angeles motor scale for the identification of stroke. I don't like these scales. It's very simple, but I like it because we can administer this in the field. It's easy to administer. Even anyone grade 6, grade 7 student can administer this and understand. So I like it. But it's very simple. It misses a lot of points, and I'm going to talk about it. So on this scale, if you see this, patient is unable to speak, trouble finding words, slurring of speech, completely mute, any language problem, garbled speech, trouble finding words, slurring of speech, or mute. This is a sign of large vessel occlusion. Okay? Here, fall rapidly. Weakness can be, you ask a patient to raise an arm, it can be just a drift. But if you raise an arm and you fall down on the bed, it's plegic, like a severe weakness. This could be a sign of large vessel occlusion. Okay? Then you use posterior cerebellar assessment. Dizziness, bad vertigo, dizziness, not resolving with any antiemetic, can be a large vessel occlusion. So let's simplify this on the next slide. So these are the signs, and if you remember this, when you're triaging these patients in the field, this will be very helpful to recognize whether this patient has a large vessel occlusion and can benefit from intervention. So as we talk about extremity weakness, we already talk about unable to speak. We already talked about trouble finding word. The other thing is gaze preference. And you can check gaze preference. It's very easy in the field. And this picture is basically demonstrating how to check a gaze. If you ask a patient to look on the right, and patient is able to look on the right all the way, follow your command as this patient is doing, there is no gaze paralysis. There is no gaze preference. But if you ask a patient to look at right, the patient is not crossing a midline. That's a partial gaze. Another patient, you give a command to look at right or left, unable to look at the opposite side at all. This is a forced gaze. Very simple. You put a finger, ask a patient to look at right, look at left. If patient is unable to look at all the way to the right or all the way to the left, that's a full gaze paralysis, and that's a sign of a large vessel occlusion. This patient probably have a clot sitting in the ICA, big vessel, or middle cerebral artery. Next is neglect. Neglect is easy also. Patient will be looking at, for example, left side and completely neglecting the right side. Like literally the word neglect, it's neglecting. You hold the patient's arm and ask, whose hand is this? Patient is going to say, yours. Patient is not going to recognize. So neglect is pretty easy. Literally you'll see, and it will be neglecting the right side or left side. Then vertigo and ataxia. This is basically the posterior circulation, the basilar artery. If you have a stroke going on in the back of the brain, then these patients can present with bad vertigo, dizziness, that will not resolve with any any kind of intervention, like if you give antiemetic or any other medication, this will be a bad vertigo. So these are the common signs that you can use to recognize large vessel occlusion. There are other signs, but that's going to be a little bit more in the field. But these are the common ones. Does that make sense? Any question about this? Do we have a good understanding of gaze and neglect? Sure.
Would you ever see a gaze preference in hemorrhagic?
Yes. So yeah, very good question. So you can see in hemorrhagic conversion also, because it's the sign of the right hemisphere. If you have a problem in the right hemisphere, then you will see a gaze preference. So any ischemic stroke or hemorrhagic stroke can give you this gaze preference. The answer is yes. Okay. Now, we talk about the timing for TPA. As I said, any patient present with stroke-like symptoms eligible for IV TPA. Now, what are the timings for thrombectomy? So in short, anything last nor normal within 24 hours is a IR candidate. So anyone with a large vessel occlusion, those 5 or 6 signs that I just explained, and the last nor normal is within 24 hours, that patient can be a potential IR candidate. We can go from the femoral approach, go all the way in the brain, pull that clot, and then I'll show a couple of pictures also. Until 2015, it was only last nor normal less than 6 hours. 2018, there was a trial, diffuse trial, dawn trial, and now it's an extended window, and we can treat these patients within 24 hours. There's definitely other criteria that we look into, which is the imaging criteria, but that's the later part we don't have to worry about, because first of all is the recognition at the bedside that whether this patient is a potential IR candidate or not, and then we can do the CT or MRI, and then we can determine the further eligibility. The other thing I want to highlight about Suburban is compassionate care, and I'll be happy to answer questions if there is. So we're treating patients, right? We're not doing studies. So there are many patients that comes to the ED and they don't fall into this criteria. Their criteria is out of the diffuse trial criteria, out of dawn trial and many other trials. But we see that there is a disability. We see a clot, but either they don't meet an imaging criteria or they don't meet any other clinical criteria like age. Like in diffuse trial, the age was 80 was the upper limit. In dawn trial, it was over 80. These other trials were less than 80. Similarly, the TPA, like MR Witness, the upper limit was 85. In Wake Up, upper limit was 80. So any other criteria that basically bring patient out of these, we still consider treatment. We talk to family and then tell them that, hey, this patient can benefit because we see this thing in the MRI, and then we can go ahead and then pull a clot. And we just did this patient like a couple of weeks ago. She had a cancer. I'm sorry, she has a cancer, and she came in with a pretty severe stroke, and she walked out of the hospital. And then I'll show the images when we talk. So what I'm saying is, because we have an NIH collaboration and we do a lot of studies, we talk to the patients, and then all these advancements, the majority of the advancements are coming from NIH, and Suburban is one of the sites we enroll all these patients for NIH. Okay, now I want to quickly present this case just to give you an idea of IR. And so at Suburban, we have 24/7 thrombectomy capability. We have 4 IR people 24/7 in-house. We do not transfer any patient to any other hospital. We keep all those patients. We give TPA. We do IR. We admit them to ICU and discharge to rehab. Entire spectrum of the stroke management is available at Suburban Hospital. So this is the case. This is, I'm sorry. So this is an 81-year-old female presented with right-sided weakness, aphasia, and left gaze preference. Based on these symptoms, how many of you think that this could be a large vessel occlusion? Raise your hands, maybe. Good. Yeah, because of this aphasia, unable to talk, and gaze preference, this could be a large vessel occlusion, right? Last normal and symptom onset was at 11:15 a.m. Triage was 1140. So patient basically presented within a couple of hours. And the NIH National Institute of Health stroke severity scale is 23. And let me explain what this 23 means. So this is the NIH stroke scale. As Shannon was explaining, that it starts from the lowest number is 0 and the highest number is 42. So anyone with a score of 1 to 4 is a minor stroke. 5 to 15 is moderate. And then you see like 21 to 42 is a severe stroke. So this patient basically presented with a severe stroke based on National Institute of Health stroke severity scale. This is the MRI. So again, as I said, that in MRI, we do number of images. It's a multimodal MRI. We get number of sequences, and we can age the stroke. So this is DWI. We see this bright spot. This is stroke. But this is another sequence, and there's a huge bright spot, and this is called area at risk. So if you subtract this small lesion from this, you will still have a lot of area that you don't see here. What does that mean? That means that this all area is at risk. It's not dead. You can preserve all this area if you intervene in time and provide appropriate management to this patient. Does that make sense? This is small. This is so big. This is the area at risk, and this is the area that I'm saying that it's dead because it's on the DWI, it's the core, it's infarcted. Most likely this lesion will stay there, okay? Now, further, we did the MRA. We see this is a clear cut. We see a good blood flow here. We don't see any blood flow here. This is the large vessel occlusion. This is the MCA, middle cerebral artery. Does that make sense? This is the stroke. This is the area at risk. And we see a clot here. Now, this is the after thrombectomy. We went through the femoral approach, went all the way up, pulled that clot successfully. Shannon showed a lot of techniques. We used one of those techniques. You see this area still there? A little bit smaller, but you don't see anything here. So this is the area that you preserve. If you don't do that IR procedure, if you don't remove that clot, this all will be dead, this all hemisphere. Now you clearly see post-procedure. There's a good flow here after the procedure. This is nicely open, and we see a good blood flow here. And these are the images, IR real-time images, angiography. This is the before. This is a clear cut, and you can just see that there's a decreased blood flow here. And this is after the procedure. You see a pretty good blood flow. Okay? So this patient discharged after 4 days, just after 4 days. Able to walk and communicate before discharge. And the discharge NIH stroke scale was 3. So just imagine, like she presented with severe stroke. The score was 23. And at discharge, this is the minor stroke. She was talking, walking, and doing everything. We did a procedure within few hours. Likely, if we don't do IR to these patients with large vessel occlusion, TPA works only 30% of times. Let me repeat that. This is important. So if the clot is sitting here in M1 or in this internal carotid artery or here, and if you give TPA, TPA works only in 30% of patients. In 70% of patients, most likely this clot is not going to resolve because the clot is big and TPA doesn't work for a bigger clots that's present more proximally. So for these patients, IR is very important. And 70% is pretty big number, and as I showed, there was a huge area. That was the area at risk, and we could have prevented that area. So this is our stroke team. I really wanted to thank you all for recognizing these cases. In the end, I just wanted to finish my talk by just saying that the timing window is extended There's no 4.5-hour window exist anymore. It's 24-hour. Time is brain. But now we can help these patients within 24 hours. If the last known normal is within 24 hours, they are eligible for IVTPA. They're eligible for IR. And our hospital, Suburban, has this IR team, stroke team, and we provide TPA and IR 24/7. And not only that, we collect all this data and then publish this, and that's called natural history. So this is the project that we are doing for last 20 years. It's called a natural history of stroke, and we do these MRI at 24 hours, and the patients who are enrolled in the study do MRI at day 5 and day 30, and then try to understand how stroke behaves over time. And this all data is basically coming from Suburban Hospital. One of the enrollment sites for this study is Suburban Hospital, and we are contributing to this data for last almost 19, 20 years. Thank you so much. Any questions? Yeah.
When you referred to us recognizing the large vessel occlusions in
Yeah.
the field, if we do a stroke alert consult, is that something you want us to verbalize over the radio or just pass on when we're at the hospital and give a report?
So I don't know how, because this is, I'm new to the system. I'm trying to understand how the EMS work, and then I think my understanding is that if you recognize the stroke symptoms, you just take it to the closest hospital, right? I don't know if based on this large vessel occlusion, you can divert the patient, but I mean, if you can tell the hospital that this is the symptoms I'm seeing, that this is aphasia or a big weakness, or gaze preference, and I'm suspecting this could be a large vessel occlusion, I think that will be a good information to pass on.
On your end, does that change as far as activating different people?
Well, it changed. So because if somebody calls me and if I know that EMS is bringing a patient and this could be a large vessel occlusion, I can activate my IR team a little bit earlier, or just gives a heads up that, hey, just look for the images. This might be a potential IR candidate. Yeah. So this is helpful. But again, by no means I'm not saying that deviate your protocol. Whatever your protocol is, do that. But what I'm saying is that recognizing these symptoms are very, very important, because we really have to activate a totally different team if there is a large vessel occlusion. Yeah, yeah. So this will be I think important information.
Doctor, do you see the other the medical community switching to MRI imaging first?
Yeah.
Like you guys in the near future?
Well, we are already.
It's very
Yeah.
expensive, and it's very.
What's the cost of MRI imaging?
Well, it's not only the cost, but you have to be careful about the patients that go into MRI. One, you need you need the cost of the tech. You also need the ability, when we have a code stroke and there's a patient on the MRI table, they pull them off immediately. We stop, everybody stops because they know that our patient's coming in. Not all, the reason why community hospitals do CT, because of the fact that that is the standard of care. It's cheaper, and you don't need the resources that you need for MRI. And the reason we have that is because of the collaboration with NIH that initially started this program back in 2000, because that was their main focus. So unfortunately, do I believe that everybody should have MRI? Absolutely.
Yeah.
But
And-
it's not feasible. They still treat appropriately with
Yeah.
CT, but the difference.
So now the thing is, everyone is trying to get MRI for a reason, because the guideline just released a week ago in 2019, and this finding, this MR witness and wake up, is a standard of care. It's a standard of care. Like within 4.5-hour window, any patient comes in, you do CT scan, CT is normal, you push TPA, that's a standard of care. Now this MR witness and wake up, this trial, these are the patients, as I was explaining, that unwitnessed stroke, where we don't have the timing, this is 25 to 30% of cases of the total community that you present that brings to the ER. So this is standard of care. So I was a part of this discussion, American Academy of Neurology, and everyone is asking for MRI protocol. Can you share your MRI protocol? Because, as I said, it's a standard of care. So they're trying to develop their protocol, not take every patient to MRI, but at least patients with a wake-up stroke and an unwitnessed at least have a protocol in place so that they can triage these patients by using MRI. So answer to that question, expensive? It is expensive, more than expensive. I don't think that MRI is expensive because you're saving a lot of money by not giving a TPA to that 20% of patients, which is stroke mimics, right? That's $10,000, $7,000 to $10,000 one patient. And I said, out of 100 patients, if you treat 100 patients, you're giving 15 to 20 TPAs to a stroke mimics, which is actually not a stroke. So you're saving a lot of money. The challenging part with MRI is basically resources. You need a technician MRI tech 24/7, and you need to develop a protocol, and then your physicians should be qualified to read MRI independently. So reading a CT scan is a different ball game, and reading an MRI is totally different. With CT, as I said, there's a one sequence you can just look at, it's normal, and there's a bleeding done. But with MRI, you have like 7 or 8 sequences. More information sometimes good, but more information sometimes gives you a problem because you see something and you say like, whether I should treat or not. So need a different expertise. Most of the general neurology people are not comfortable reading MRI, so need to have a vascular neurology training. So those challenges are more, I think, more compared to the money. I mean, healthcare cost is already. I mean, I don't have to tell you. Sorry, your question?
The patient has to be more compliant.
Patient has to be
More compliant.
more compliant.
For receiving an MRI scan.
Yes, I mean compliant means you mean like, do not. Yeah, that is a challenge. So the other piece of it is metal screening. If they have a pacemaker, now we are having MRI compatible pacemakers, but definitely moving all over the place or altered mental status patients, then you have to sedate those patients a little bit. But I think if there is no contraindication, sedating those people is a reasonable approach, because then you're getting a lot of information that you can help those patients. Sedation shouldn't be a problem. It's a safe procedure. Yeah, but you're right that they have to still, like, definitely more than for 15-20 minutes. Yeah.
We bring a patient with a large vessel occlusion to a facility that can't do interventional radiology. Based on the TPA being effective only 30% of the time, will that generally be given? Is that the standard of care
Yeah.
to give the?
Yeah. So the American Heart Association, their position is no matter whatever the recanalization rate is, you should give TPA regardless. Whether this patient is a large vessel occlusion and IR candidate, TPA is the standard of care. So we give TPA because we don't want to miss that 30% of cases that can recanalize. So I can share quickly if you have a time that just this weekend I was on call and there was a patient in the hospital with a stroke-like symptoms, and they pushed TPA. It was a pretty big large vessel occlusion, pretty high NIH stroke severity scale. That we transferred to Suburban Hospital. We transferred patient directly to the IR, and I said like, there's no point of bringing this patient to ED. Just take it directly to IR. Patient was in the IR. I was just about to. They were just about to start a procedure, and I said like, she's moving right side. Something doesn't seems right. So I said like, let me examine this patient. I examined that patient. Examination was normal. NIH stroke severity scale was 0. I said like, I don't think this makes sense. So I sent that patient for MRI, looked at it, normal. So the clot resolved by TPA. So there are 30% of cases when you save that IR procedure, that's $100,000 procedure. So you save. So it's all about evidence-based medicine. If the patient is TPA candidate, you give TPA. If the patient is large vessel occlusion, not improving, you do IR. So there's a metric that you have to follow. But bypassing TPA is not an option. Does that answer your question? Yeah. Okay. Any other questions? Any questions from?
Well,
Yeah.
Thank you for the instruction, because actually, when we just got hot off the press, the guidelines, I
Yeah.
was like, okay, how, especially for more so the community hospitals
Yeah.
that don't have the resources that you
Sure.
guys have, and including that in our protocol. So we actually gonna have a meeting about it tomorrow, so we'll
Good.
figure it out
Sure.
and see. And
Right.
at least for certainly the unwitnessed wake-up stroke
Yeah.
patients,
Yeah.
we already are doing the MRIs anyway,
Yeah.
typically.
Yeah.
But incorporating if it's negative or flare, giving TPA if it's within 24 hours of
Yeah.
last time seen normal, would
Mhm.
be a change in
Yeah.
mindset for
Yeah.
our providers.
Yeah.
So
Well, I
we'll
think-
see how it's going
right.
to evolve, but
Yeah.
especially your community hospitals that don't have the resources that you guys
Yeah.
have.
Right, right. I think this is a good point that every community hospital has MRI, right?
Right.
I mean, it just developing a protocol that identifying a these patient, and instead of doing an MRI after 24 hours when receive TPA, just do it early. So I think it's just developing a protocol. MRI is available in every hospital. I mean, they do it MRI, like you have showed it. It's just developing a protocol for those patients that can benefit. Like if this patient present within 4.5-hour window, CT is normal, push TPA, that's fine. But just I completely agree with that. It's really challenging when we started, and then those challenges. I mean, we've been doing this for like 17, 18 years, but still there's a room of improvement, continuous quality improvement, and sometimes the process issues all. I mean, every day is there, and then we just have to deal it and troubleshoot based on the problem. But yeah, it is challenging. But I will say that this is the future, and now we have to do it because this is the standard of care. It will take time, but I'm very happy and I feel proud that I'm trained at NIH and at Suburban Hospital because we are doing this practice since 2012. And there was a lot of pushback when we present all this data in a meeting that what are you talking about? MRI is so expensive. MRI takes like 15 minutes. Time is brain. Door to needle time is 60 minutes. Now we have proved that time is brain, but then we are treating these patients within 24 hours. Like we were not managing these patients. We were not treating these patients if they were out of 4.5-hour window. So time is brain, but there is still ischemia. There is still tissue that you can preserve. So now I think people are starting realizing and started doing MRI and then developing a new protocols.
Because currently we have, for example, if we're not able to do the CTA,
Yeah.
and they are within the 24 hours,
Yeah.
LVO, we'll do then a quick party on MRI. That includes really the diffusion, the ADC.
Yeah.
But now,
Yeah.
based on the MR witness trial, should we just include flare?
Yeah, yeah. Because the wake up and MR witness both is basically based on the flare. Actually, it's the flare that tells you that actually age the stroke. That you can tell whether this stroke happened a week ago, or 2 weeks ago, or 4. And it's really interesting and fascinating when you look at these images, and then I mean, all this information is so mind blowing that when you see these patients, like they go to CT based triage, didn't get TPA or anything, but came here, get TPA, walk out of the hospital. It's amazing. Sorry, you have a question?
Just one last, you referenced ages, maximum ages for these studies.
Yes.
Are you still utilizing ages?
So
do we consider anybody outside?
We do, but I have treated out of the protocol 102 years old. I have treated 99-year-old. I have treated 97-year-old. It's safe. It's safe. So it just, again, as I was saying, that we're not doing study. We're treating our patients. So if someone, so let me explain this. So in 1995, the NINDS trial, they said we're going to treat patients less than 80 years of age. So anyone who presents with last known normal of 4.5-hour window and age less than 80, we will treat these patients. And they were excluding all those patients presented with like more than 80 years of age, 81, 82. After 2-3 years, they did some analysis and they found
that the patient less than 80-year and more than 80-year benefit equally. Now they have changed. So now for 4.5-hour window, for this window, there's no cutoff. There was a, when NINDS in 1995, they said if the patient is more than 80 years of age and has a history of diabetes, don't treat, right? Now we treat those patients. Then there was another guideline, they said like if the age is more than 80 and they have a previous stroke, don't treat. So all these things are evolving. Now there's a current guidelines, like current recommendation is if somebody has a stroke within 3 months and had another stroke within 3 months, don't treat, right? But now the guidelines are flexible, and I have treated many patients, like if the disability, if the deficit is huge and the previous stroke was small, so we weigh basically risk and benefit, and we treat those patients. So we follow the guidelines. We don't, I'm not saying that we don't follow guidelines, we follow guidelines, but if we see that this patient deficit or disability is higher, the risk of having a bleed or anything is lower, we go ahead and treat. It just talk to the family and tell them, and amazing results, great findings. I mean, as I said, Suburban is a very interesting population. Our stroke patient average age is like 86 or 87. Like 50 to 60%, right, Major? 50 to 60 or 70% of patients are over the age of 80.
Well,
Yeah.
Probably at least over 65.
Oh, 65 for sure. I mean, whenever I'm on service, like 60, 70. I mean, I don't know, 60, 70 of percent of service is over the age of 85 or 90, 92. So, and they are basically very different population because their risk factor profile is great. It's all about risk factor. It's all about controlling your blood pressure, your diabetes, your high cholesterol level, exercise, and somehow I did my rotation in DC also. Very different population, you know, like very different population. Like, and then you presented like pretty much every case was less than 40 years of age, right? And I said like, what's going on in this area? And I see like over the age of 90 and 85. So it's all about risk factor modification, and I mean we have these treatments, acute treatments, but that's when you cross that bridge. Any other questions? I hope this was helpful. I just tried to put the timings together so that because you are the people who recognize a stroke first, and if you suspect something, that is helpful for us. And thank you so much for doing that.
Thank you.
Someone lined up to represent him instead, a doctor from the ER who had a family emergency and was not able to come. So we're short one presenter, or we would have gone to probably noon, but you're going to get 4 hours of Con Ed for being here. Because the MIMS number has 4 hours, so you get 4 hours. So you can go home and go back and share this with providers that might not have been either with our live streaming or here in person to, again, raise awareness and make sure that people are thinking about these large vessel strokes and sharing what you learned. And thank you again to Jose and to Zach for being our newbie presenter. That was great. Thank you so much. And the tablets are ready for you to sign out. And we're going to take down the feed, I believe, Courtney. Sure?
Yeah, you
You're
got
going to print, yeah. You're going to print out like you did last time.
Oh, yeah.
That was right. And stay tuned. We'll be doing this again next year. Dates are not, we're still working on this fall, finalizing the rest of the Con Ed. The next year calendar will be coming out, and our plan is to continue the live streaming. So when you're here in the room, you get overtime. When you're out in the field, you get your Con Ed, and it all works. So join us when you can, either in the classroom or online. Thank you for coming. Sign out on the tablets, please. Make sure you select Grand Rounds when you sign out.